we'll be discussing about renal dysfunction, both acute and chronic. Both forms we'll try and cover in this 1 hour, which is not an easy task. Nephrologists will not at all agree that two topics can be covered so quickly. Nonetheless, whatever we can, we'll try and cover. So, kidneys, we have two of them. Fortunately, we have two of them. So, but sometimes we ask too much of it, of the two kidneys. Yeah, everything depends on them for elimination of unwanted nitrogenous waste, metabolic waste compounds. If we are not able to eliminate those metabolic compounds, the nitrogenous waste compounds, then that is eventually going to take a toll on us, on our health. So we owe a lot to our kidneys. So we have to ensure that we do everything right, and not put them under too much stress. So drinking adequate amount of water goes a long way in maintaining good renal perfusion, which is very, very important. That's why even on World Kidney Day, most nephrologists would be advocating for drinking a lot of water. The problem sometimes with the climate in a place like Bangalore is you don't feel very thirsty because it's not very, very hot or not very warm or not very humid. So you tend not to drink water consciously because you feel you're okay, you're not dehydrated. That's where the problem lies. If you're not drinking adequate amount of water, no, at least 2.5 liters of water, drinking water per day, then the body has to try and use the water from within our body. So all men, uh, except for elderly, very elderly men and women, most adult men and women, 60% of men have their body weight as water and 50% for women. So the body has to use that to try and maintain renal perfusion and maintain adequate urine output to excrete all the nitrogen waste compounds. So it's very important that we consciously drink adequate amount of water every day based on where you stay, where you live. If it's a very hot weather, then definitely, like perhaps in Chennai and all that, most parts of the year, you'll have to drink a lot of water just to make sure your kidneys are well perfused. But otherwise, even then, 2 to 2.5 liters of water every day is very good, very healthy for kidneys. So make it a habit. Get up in the morning, drink 1 liter of water. Finish that, at least 1 liter of your quota of daily water in the morning itself, so that the rest of the day somehow you'll be able to make up 1.5 liters more. So that's good for your kidneys. So that's the thing. So when there is renal dysfunction, acute or chronic, the very initial stages will go unnoticed, will not get picked up. So that is the problem, because we have two kidneys and each kidneys have so many million nephrons that they will somehow try and make up for a few lost nephrons, or if there is a stressor or a stress factor that is causing the kidneys not to be able to function as they are supposed to. If they're not able to, then somehow there'll be compensatory mechanisms to try and maintain renal functions, but then eventually the dysfunction will manifest. So when we talk about acute renal dysfunction or acute kidney injury, so terminologies are important. There has been a change in terminology more than a decade now, where earlier we used to call it as acute renal failure. Now the preferred terminology is acute kidney injury. I hope you are all aware of this. Please don't use the term acute renal failure. There is something called renal failure, but we don't use it routinely. We just say acute kidney injury only. So whenever you're trying to denote acute renal dysfunction, use the term acute kidney injury. So, and the chronic renal failure, the terminology chronic renal failure was replaced by chronic kidney disease. So both terminologies removed the renal part, and whereas failure would mean that it is the ultimate consequence. It's like saying liver cirrhosis and not paying attention to the chronic hepatitis or the acute hepatitis part. So that is why failure might convey a wrong message, might be perceived in a wrong sense, both by medical fraternity as well as lay people. If you give them a diagnosis that you have renal failure, they may perceive it differently. So they may perceive that this is the end stage. So a lot of times it's not the end stage, and very, very important to recognize that there are these interim stages where intervention definitely helps. And therefore, these terminologies were done away with KDIGO, the kidney disease improvement in global outcomes. That is the authority that changed the terminologies. Now, acute renal failure is acute kidney injury, chronic renal failure is chronic kidney disease. correct? So we'll discuss about these in the next, hopefully 1 hour and plus. Okay, so what is renal function? What does the kidney do? It helps to maintain fluid homeostasis. So because we are excreting urine as a liquid, we are able to eliminate some amount of excess fluid. Then, of course, mainly the fluid acts as a vehicle to try and excrete the metabolic end products, or rather byproducts or waste products, so to say. So these are mainly nitrogenous compounds, because these metabolic waste products mainly have nitrogen. That's why these are most often nitrogenous compounds. Like, for example, blood urea nitrogen, or rather urea. Maybe I should not write blood urea nitrogen, urea and creatinine. These are all waste compounds which are eliminated. They have nitrogen in them, no? So that's what the kidney does. Electrolyte homeostasis, potassium excretion is very, very much the kidney's domain, as well as acid excretion. So that is why is our blood pH alkaline? Because the kidneys are able to excrete the hydrogen ions. So because the kidneys are excreting excess amount of hydrogen ions, our blood remains alkaline. Our urine usually is acidic, usually towards the acidic side. Okay, usual pH of urine will be less than 7. Blood pH will have to be more than 7. That is 7.35 to 7.45. You guys know that. Okay, endocrine functions. How many of you guys are online? Uh, can you guys name the hormones which the kidney secretes? Hi, Nahum. Nahum said hello on YouTube. Can you guys tell me what are the hormones that are secreted by the kidney, or synthesized by the kidney? Some of the hormones, can you name them? Normally synthesized by the kidney. Help me to revise the hormones. Very good. Chinmay has said erythropoietin. Excellent answer. Erythropoietin is one of them. Any others? I'm sorry, I shouldn't put a question mark. Yeah. Any other hormones secreted by the kidney? Maybe not secreted, but the end product, the active product, is synthesized there. Renin, excellent answer. Yes, that is true. Renin. Chinmay, excellent. We have an answer from 3251. Erythropoietin, excellent. HIF. Could you expand HIF? Did you mean hypoxia inducible factor? We'll take it as a part of the erythropoietin. So hypoxia inducible factor is what generally helps to maintain erythropoietin secretion. Very good. Medicofit says vitamin D. So active form of vitamin D is indeed synthesized in the kidneys, correct? So each is synthesized in a different area. So erythropoietin is synthesized in the peritubular cells, interstitial cells, basically. So if you come across a predominantly interstitial, yeah, 30 to 51, very good. Hypoxia inducible factor. That's also correct. That's also correct. That in turn leads to erythropoietin secretion. So peritubular cells, or the interstitial cells, are what are responsible for synthesis of erythropoietin. Renin is synthesized where? In the juxtaglomerular apparatus, correct? It's synthesized actually in the afferent arteriole. Renin is secreted from the afferent arteriole granular cells, which is a part of the juxtaglomerular apparatus. That's the renin. And vitamin D is synthesized in the proximal convoluted tubule. So the PCT has a lot of reabsorptive functions, but it also has synthetic functions, where it has this enzyme 1-alpha hydroxylase, which helps to synthesize active form of vitamin D. The 25-hydroxy vitamin D is synthesized in the liver. You guys know vitamin D synthesis, right? So dehydrocholesterol then becomes cholecalciferol, then that becomes 25-hydroxy vitamin D in the liver. 1,25-dihydroxy vitamin D is finally synthesized in the kidney. That is the active form of vitamin D. So it has its endocrine functions also. So what you should keep in mind is, when the kidney takes a hit, when the kidney is injured, if there is an acute kidney injury or a chronic kidney disease, some of these functions may be lost. Some of these may not manifest immediately. So in an acute renal dysfunction, acute kidney injury, you may not get to see all of these, especially this one may not be very evident, but in the chronic form, definitely it might start manifesting. Okay, whereas these may manifest quite, whether it's acute or whether it's chronic form of renal dysfunction. Okay, one more maybe I have not mentioned. See, so the kidneys, what are they doing? They are trying to make sure that whatever is waste is excreted, and whatever is necessary, what is important is conserved, right? It's not excreted. So for example, cells like RBCs, WBCs, or even proteins. I mean, some proteins, very, very low molecular weight proteins may somehow find their way into the urine. So urine has up to 150 milligrams per day of proteins may be present in urine, correct? Urine protein, that's normal. And in that, up to 30 milligrams may be albumin. Albumin is a very low molecular weight protein, but its concentration is more. That's why the oncotic pressure exerted by albumin is much more than the other proteins. But its size is very less, so it can get excreted up to 30 milligrams per day. And the rest of the normal urine proteins can be made up by secretory IgA, can be made up by something called TAM horsefall protein, and certain other peptides. So even these proteins beyond this limit should not be excreted in urine, should not be lost in urine. So conserving some of the important components of blood is also one more kidney function, right? So if there is either what do you say, a failure to excrete what needs to be excreted, or a failure to conserve what needs to be conserved. So if instead RBCs are being lost, proteins are being lost, that is also a form of renal dysfunction. So you should not forget this aspect. The kidneys are meant to excrete fluid, meant to excrete byproducts, acid, potassium, and all. But it's also meant to conserve cells, conserve proteins. If that function is affected also, it means it indicates renal dysfunction, renal disease. It's failing to do its job, basically. And then the endocrine functions. Okay, so that's just a very brief mention about how important functions are performed by the kidneys. And of course, you should also remember how well perfused they are. Kidneys are perfused. They receive about 20% of the cardiac output. So almost 20% of the cardiac output goes to the kidneys only, so as to allow them to be able to function like this, to perform all these functions. Okay, so just a recap of what happens at the nephron level. Nephron, of course, each individual nephron has this the glomerular capillaries. This is the Bowman's capsule. Okay, and so totally, they are responsible for the filtration function. So the glomerular capillaries, along with the Bowman's capsule, it has the visceral and the parietal epithelial layers, through which there is filtered fluid with which contains the nitrogenous wastes and other compounds will then pass through the tubules. In the tubes, and there'll be an exchange between the tubules and the peritubular capillaries. Some substances get reabsorbed, including water, and get reabsorbed, and some may continue to get secreted. So there's something called tubular secretion. That's an important process, tubular secretion. Okay, so basically, when the final urine comes out through the collecting duct and beyond into the renal pelvis, into the ureter, urinary bladder, and urethra, and then comes out, it will be a sum total of the glomerular filtrate minus what has been reabsorbed, and then finally some additional amount of secretion. So tubules secrete also, tubules reabsorb also. So let's say water, around 65% of water gets reabsorbed in the PCT itself. That's an obligatory manner. In an obligatory manner, 65% of water gets reabsorbed. And then in the collecting duct, again, that is a facultative reabsorption which occurs using ADH. So ADH can end up reabsorbing very large amounts of water based on how much GFR there is, how much blood flow towards the tubules there is. So water itself gets reabsorbed quite a lot. Amino acids, glucose, all these get reabsorbed in the PCT. Okay, phosphate, yeah, uric acid also. So uric acid reabsorption also occurs in the PCT. Very importantly, creatinine. So even urea, okay, urea and uric acid both get reabsorbed in the PCT. Very important point is creatinine is excreted. Creatinine is not just filtered, it is also secreted. Creatinine not just filtered but is also secreted. So tubular secretion of creatinine takes place. This will be important when we discuss about this difference between pre-renal and renal AKI, acute kidney injury. Why the 1 to creatinine ratio is high in pre-renal, not not so high in renal causes of AKI. Okay, so remember what creatinine is. Creatinine is just a waste product. I'll just highlight that in just a bit. Okay, so and then finally, after the peritubular capillaries, they get drained of their oxygen. Kidneys demand a lot of oxygen because the oxygen consumption in the nephron is very, very high. So that's why they need a very good perfusion. So anytime that there is a volume reduction, intravascular volume reduction, the kidneys will take a hit. There is every chance that if you are giving diuretics, if you are causing dehydration, or if the patient is experiencing dehydration for some reason, they may have renal dysfunction in the form of acute kidney injury. In fact, sugarcane farmers or sugarcane workers, those who work in the sugarcane fields, generally, sugarcane is grown in some of these hot areas, okay, including my own state of Karnataka. Uh, it's been found that many of these sugarcane workers, they end up becoming dehydrated repeatedly because of their harvesting of the sugarcane uh, produce, and that is why they have a higher risk for CKD. So CKD seems to be more common among sugarcane farmers. So that is something that has been found in multiple studies. So repeated episodes of dehydration can even lead on to chronic renal dysfunction, not just acute. Okay, so that's why kidneys require a lot of water, require a lot of blood flow, for which you should drink a lot of water. Okay. Yeah. So otherwise, what is there? Prostacyclins are there. So this afferent arteriole is what is coming out of the arcuate arteries. So the renal arteries, they branch into lobular arteries, and then the arcuate arteries into afferent arterioles. Afferent arterioles, they divide into capillaries and then join back as arterioles only. So this is what is called a portal circulation. No, portal circulation is when instead of an artery giving rise to capillaries and then going back as a vein, which is happening at this level. But at this level, the capillaries are going back as arteries only. So that's why it's a type of portal circulation, just like even in the hypothalamus and the pituitary. That is also a type of portal circulation. But basically, the afferent arteriole is just bringing the blood for getting filtered in this Bowman's capsule, and it's called renal corpuscle. So the combination of glomerular capillaries and Bowman's capsule is called renal corpuscle. So in this, there is filtration happening, and whatever remaining blood is going out again in an arteriole only. So the purpose of this is you can try and alter the blood flow from both ends. You can try and cause vasoconstriction in the efferent arteriole and vasodilatation in the afferent arteriole to try and maintain high intraglomerular pressure. So the vasodilatation of the afferent arteriole is done by the prostacyclin. So PGI2, that's prostacyclin. Whereas efferent arteriole vasoconstriction is mediated by the angiotensin 2. Angiotensin 2 came about because of action of renin, right? So renin from here, afferent arteriole, that went and it brought about all the changes, right? So it went to act on angiotensinogen. Angiotensinogen was converted to angiotensin 1, then angiotensin converting enzyme that acted and produced angiotensin 2. So angiotensin 2 is acting at this point. So what you should remember is if you were to oppose these, you might end up reducing the GFR. So one of the causes of acute kidney injury is drugs which oppose prostacyclins like NSAIDs, or drugs which oppose angiotensin 2 like ACE inhibitors and ARBs. Okay. Okay. That's about this. Okay. Just a question for you guys. When you're trying to make a diagnosis or dealing with acute kidney injury, which of the following is the least appropriate indicator of renal function? Urine volume and color, serum creatinine and blood urea nitrogen, estimated GFR using CKD EPI formula, creatinine clearance calculated by the actual measurement of the urinary volume and the urinary creatinine, urinary volume, and plasma creatinine, or the DTPA scan. and other scintigraphy scans. DTPA and radionuclide scans, Chinmay said, very good. Let me check on YouTube. Okay, lagging behind a little bit. So DTPA and other scintigraphy scans like MUG scan and all that, these which basically employ either like a technetium 99, which tries to see how it's getting filtered, the particular dye or radio tracer is getting filtered. You can use it in acute kidney injury also. So if you want to try and make out, is there acute kidney injury, are the kidneys not functioning normally, you can use the DTPA scan. That gives you an assessment of the functional status of the kidney. That is okay. So this answer is okay. Creatinine clearance, obviously, this is perhaps one of the more accurate ways. If you can't do this, is the most accurate. But if you can't do that, at least you can do this. If you really want to measure the GFR, which is basically the creatinine clearance, you can use this, but you need to calculate. So the urinary creatinine, plasma creatinine, urinary volume, little cumbersome, but you'll get a very near accurate value. Okay, urine volume and color, yes, definitely very, very important, because in fact, urine volume is used for defining acute kidney injury. Serum creatinine, blood urea nitrogen, very, very important. Serum creatinine is used for defining acute kidney injury. Estimated GFR formulas, you have to keep in mind, estimated GFR formulas were not designed to measure to estimate the GFR in a patient with dynamic changes in the renal parameters. So it's not meant for the formula itself says CKD EPI. It's called CKD epidemiology formula. It's not accurate when the creatinine rises and falls over short periods of time. When the creatinine is at a stable level, then you can use it. So please remember, even if tomorrow you're using it on a patient with acute kidney injury, yesterday creatinine was 1.3, today creatinine is 2.6. If you apply this formula, it will not give you a very accurate estimate of the actual GFR. So if you really, really want to measure the GFR, you can either go for these. Okay, these can help to define and stage, but it will not really give you an idea of GFR. The GFR measurement is important when you're trying to use drugs, basically. So when you're giving medications, you have certain cutoffs, you have certain dose adjustments that you have to make with regards to GFR. So to try and estimate GFR in an acute setting, these two are better, although this is not so easy. This is perhaps the closest you will come. This is not appropriate for acute settings. Okay, so please remember, there are these formulae called eGFR, estimated GFR formulae. The currently recommended one is CKD EPI 2021, which is not meant for use in acute kidney injury. So just a practical point I wanted to put in there. Okay, so this is how DTPA scans would show how the tracer is getting filtered, how the kidneys are able to filter or not able to filter. Basically, you can get a close enough estimate of the renal functional status. Okay, there's a similar scintigraphy scan for structure, and that is called DMSA scan. Okay, DMSA scan is for structure of it's a static scan. You don't get like functionality in it. A static scan where you get the structure of the renal system. DTPA is used for functional assessment. Okay, diethylene triamine pentastic acid. That's what DTPA stands for. Anyway, so what is to be kept in mind very importantly when you're dealing with patients is when there's an insult to the kidney, straight away there is no way to detect that the kidneys have taken a hit. Whatever you use, whether you use urine output, whether you use serum creatinine, it takes time for those to become abnormal. So we don't really have great parameters to try and help pick up renal dysfunction early. So that at the initiation stage of renal dysfunction, acute renal dysfunction, we may not be able to diagnose for even up to 24 to 48 hours in the initial stages, because as there's an insult, there's going to be a compensatory mechanism that gets kicked in, and that will help to try and maintain the GFR. So glomerular filtration rate and therefore urine output and serum creatinine may remain normal in the very initial stages of acute kidney injury. So that is why renal failure may follow some time after the actual insult. So that's why acute kidney injury is the preferred term instead of renal failure, because of the compensatory mechanisms. What are the compensatory mechanisms? Chiefly, there are two main. One is the myogenic reflex that we talked about, where there's going to be vasoconstriction of the efferent arteriole and vasodilatation of the afferent arteriole. So whenever there is going to be a change in the volume status that will help to coordinate uh, how much of tone should be there in the afferent and efferent arterioles. Prostacyclins will mediate the vasodilatation in the afferent arteriole, whereas angiotensin 2 is what mediates the vasoconstriction in efferent arteriole. Okay, so by trying to make variations in these, it will maintain intraglomerular pressure and maintain the filtration, GFR. The other one is, of course, tubuloglomerular feedback. So based on how the flow is within the lumen of the nephron, the macula densa cells will get activated. Macula densa cells are present in just beyond the distal part of thick ascending loop of Henle, and from there they will try and communicate with the juxtaglomerular apparatus, the afferent arteriole. The granular cells, they will secrete the erythropoietin, and the erythropoietin will then work uh, to try and produce more angiotensin 2. Angiotensin 2 in turn also helps in producing more aldosterone. That is not shown here, but aldosterone also tries to act on the collecting duct to try and retain more fluid. So intravascular volume is increased, and there is vasoconstriction, especially in the efferent arteriole, as well as generalized vasoconstriction to try and maintain all blood to be pushed towards the kidney. So angiotensin 2 is producing vasoconstriction in the rest of the body also, and in the efferent arteriole to try and maintain good glomerular filtration. So these two reflexes, the tubuloglomerular feedback, based on tubuloglomerular feedback, how much of flow is there, how much of urine flow is there within the lumen of the tubules, will dictate what is the feedback given to the glomerulus. Either there should be vasoconstriction or there need not be any additional vasoconstriction based on renin secretion, as well as the myogenic reflex also based on intravascular volume status. Okay. Finally, if the compensatory mechanisms are overcome, then they'll have a drop in GFR. Once there is a drop in GFR, there can be an elevation in nitrogenous wastes, as well as a drop in urine output. So a drop in urine output also. So these are the two ways we can detect acute kidney injury, but that too after certain lag. So 24 to 48 hours, you may not be able to even make out that there has been a kidney injury. Only slightly later, it'll reflect in either a reduction in urine output or an increase in the creatinine levels or urea or blood urea nitrogen levels. Okay. Remember, there's a delay. Okay. So just a word on urine output. Is it a good way to make up, or to try and make out whether there is acute kidney injury? Yes, it is, especially when there is pre-renal AKI. In fact, in pre-renal AKI, do not rely on creatinine so much. If the precipitating factor happened today, let's say a patient had cholera, and the patient is having a lot of vomiting, a lot of rice water stools passing out. So a lot of stools, very liquidy, very watery, full of mucus. Okay, it can be deadly. The amount of fluid they can lose, cholera. Okay, very, very important to resuscitate very aggressively. So if they have the let's say 20 episodes of loose stools today with vomiting, the creatinine will remain normal today, may even remain normal tomorrow. Okay, because of tubular secretion continuing, but the urine output will start coming down. So urine output is a good indicator of renal dysfunction in pre-renal causes of acute kidney injury. And pre-renal causes of acute kidney injury is either true hypovolemia or effective hypovolemia, basically a reduced blood flow to the kidney. So that's why urine output is a good indicator in pre-renal AKI. Yeah, maybe 50%, roughly 50% of AKI may still remain non-oliguric. So they're producing urine. You can't make out that they're having acute kidney injury based on urine output, though their other parameters may take a hit, like the urine nitrogen and creatinine. So color of the urine also very good indicator. So you always try and make out whether it's dark or high colored, or is it normal colored. Sometimes if they're in the diuretic phase, acute tubular necrosis, classically, there are four phases of acute tubular necrosis: initiation phase, the oliguric phase, diuretic phase, and recovery phase. In the diuretic phase, so much of water, so much of urine is being lost. Polyuria is there. In that case, the urine becomes very uh, light colored, okay, very faint. So the color also helps to determine the rough osmolality. This is in resource limited settings if you can't really analyze the urine. So in pre-renal AKI, urine output is a good indicator. So any patient who's having a lot of loose stools, lot of volume loss, please ensure you ask them how much urine are you passing? Are you passing urine adequately? So if they're not admitted before admission, if they're admitted, then you only monitor it real time. But otherwise, if let's say a neighbor comes to you and says, I'm having a lot of loose stools, what to do? Just ensure that they're well hydrated. Good indicator is how well the kidneys are perfused. If they're producing good amount of urine, a good indicator that they're at least adequately hydrated. They may still have renal injury. They may still have acute kidney injury, but at least if they're passing urine, there's a good chance that it will reverse early. Okay, blood urea nitrogen is less specific than creatinine because it may even be increased, let's say, in high protein diet. So patients who are on high protein diet will have a high blood urea nitrogen. Okay, blood urea nitrogen is nothing but urea divided by 2.14. Okay, BUN is urea only, but divided by 2.14. So either you can use urea, blood urea, or you can use blood urea nitrogen. Both are okay. Urea cutoff is usually around 45 milligram per deciliter. Okay, so 45 divided by 2.14, you can take it somewhere around 25 as the cutoff for blood urea nitrogen. But it's less specific. It can be seen in other conditions. And the problem is urea is reabsorbed from tubules, whereas creatinine is secreted from tubules. So that is why urea levels are always, the ratio of BUN to creatinine in pre-renal AKI is always more than 20. That is because of urea being reabsorbed and creatinine being excreted. Sorry, secreted. Okay, secreted, tubular secretion. So otherwise, gold standard what we use is creatinine, the most commonly used parameter. It's a waste product, total waste product. So that is why muscles have creatine. So creatinine becomes yeah, I've written here. Creatine becomes creatinine finally within the muscles. So you also have to keep in mind how muscular the person is when you try and interpret the serum creatinine value. If you're uh, seeing the serum creatinine value report, you have to make sure you keep in mind the muscle mass of that patient. So a very well built, very hefty person may have normal renal functions, but the creatinine, serum creatinine value may be like 1.1. Whereas the same 1.1 in a very short and very, very lean individual may indicate an elevated value because relative to the muscle mass, very light, very small amount of muscle mass, but relatively higher serum creatinine always indicates that there may be a renal dysfunction responsible for the creatinine elevation. So filtered as well as tubular secretion both occur. That is why when you are seeing a patient with cholera and all, no, creatinine will rise the next day. It will not be risen in the first day or when the patient comes to you. That time the urine output would be coming down, but the creatinine will still not be very high. It will start rising the next day. Likewise, the recovery also. Recovery also, urine output recovers first. Creatinine starts to come down later. So in pre-renal AKI, you use urine output. Renal and post-renal, you can use creatinine. That's the best we have, creatinine. Okay, just a few points about creatinine. Rises within 24 to 48 hours, renal ischemia, atherombolization, radio contrast exposure. Also in allergic acute interstitial nephritis. So let's say you gave a patient NSAIDs. He's already had NSAIDs in the past and developed previous episode of acute interstitial nephritis. And now again, you gave them NSAIDs not knowing about the previous history. And that might result in allergic acute interstitial nephritis. Same thing. The 24 to 48 hours later, the patient's creatinine will start rising. Okay. So this pattern may be seen. Otherwise, it may be a slightly delayed rise. For example, in ischemic acute tubular necrosis, where it might rise and then peak at around 7 to 10 days and resolution over the next 7 to 14 days. So I told you the 4 stages: initiation, oliguric, diuretic, and recovery phase of acute tubular necrosis. Acute tubular necrosis means the tubule is necrosed. So either the tubule is necrosed because of ischemia, which means hypovolemic, which means pre-renal. Pre-renal AKI can, if it persists, no, pre-renal AKI, if it persists, it will land into acute tubular necrosis. Or there may be direct impact, direct trauma, so to say, direct pathology of the tubules, like for example in sepsis. So in sepsis patients also acute tubular necrosis can happen because of direct injury to the tubules. Okay. And then finally, certain other pathologies like epithelial toxins, like drugs like aminoglycosides, cisplatin, there can be an increase slightly later, 7 to 14 days later. So it might it might be a slightly slower rise in creatinine values with regards to drugs like these aminoglycosides, cisplatin. Contrast I had mentioned. So contrast, it takes generally 48 hours. So contrast induced contrast induced nephropathy, don't repeat the creatinine the next day. Repeat it after 48 hours. Okay, so if you have given contrast today and you are worried about contrast induced nephropathy, might take 48 hours for the creatinine to rise. So don't repeat it immediately. Repeat after 48 hours. Okay. Mm, yeah. So now coming to actual acute kidney injury, what is the definition? There's a description. Descriptive definition would be characterized by loss of ability of the kidneys to do its job, basically. So excrete waste, concentrate urine, conserve electrolytes, maintain fluid balance. This is correct. But how do you know that a patient has or does not have acute kidney injury? So remember, there are three things there: acute, kidney, and injury. For acute, we need a timeline. So the earliest that you can make a diagnosis of acute kidney injury is 6 hours based on urine output. Okay, if the urine output is less than 0.5 ml per kg per hour for 6 hours, that is the earliest you can make a diagnosis of acute kidney injury. So this is useful in pre-renal AKI. Renal AKI, urine output may remain preserved. So you are more reliant on creatinine. So how do you know it's a kidney problem? Based on creatinine. So creatinine elevation will decide if it has elevated by at least 0.3 milligram per deciliter over 48 hours or 1.5 times the baseline. If you had a baseline prior to the patient's presentation, patient had a baseline creatinine level recently measured creatinine that was normal, or that was some level. Compared to that, now 1.5 times there's been a rise in the creatinine value, at least over 7 days, within 7 days, that is within 7 days, then that is also considered as acute kidney injury. Okay, so remember the timelines: 6 hours, 48 hours, 7 days. That is what acute denotes. Okay. That is what acute denotes. I'll show it again, I think. Yeah, here it is. So based on urine output, either for minimum of 6 hours, 0.5 ml per kg per hour urine output. That's the earliest you can make a diagnosis of acute kidney injury. Otherwise, if the creatinine from baseline has gone up by at least 1.5 times within 7 days, or 0.3 milligram per deciliter or more within 48 hours, within 2 days. Okay, these are the timelines. And then there is staging. So stage 1, stage 2, stage 3, acute kidney injury. What is the purpose of staging? Not routinely done also. I'll be frank, we don't, in practice also, we don't, very often we don't stage them because it doesn't make too much of a difference with regards to management. Nonetheless, these are the stages: stage 1, stage 2, stage 3. Stage 1 is 1.5 to 1.9 times of baseline. Stage 2 is 2 to 3. So you can remember 2 and 2. 2 to 2.9, that is 2 to 2.9 times of serum creatinine baseline, and 3 onwards, or if the absolute value is 4 or more, or if the patient has been initiated on renal replacement therapy. RRT stands for renal replacement therapy. Or if in a what do you say, in a child, that means less than 18 years, if the EGFR is less than 35. But I told you EGFR is not great for calculation in acute dysfunction. So that's not the ideal way to make a diagnosis of stage 4 AKI, stage 3 AKI. But nonetheless, this is how staging is done based on creatinine. Otherwise, urine output wise, if it's for 6 hours, then it is stage 1. If it continues for 12 hours, then it is stage 2. If it is less than zero point 0.3 ml per kg for 24 hours or anuria for 12 hours or more, then it is stage 3 AKI. Okay, so it's zero point 0.5 for stage 1, stage 2, zero point 0.3 for 24 hours for, otherwise it was 6 and 12 hours. Then it comes 24 hours, but it is 0.3 ml per kg per hour for 24 hours or more, or anuria for 12 hours. The thing about this, no, I've always been confused. Anuria, can anybody tell me what is the definition of anuria? When do you say anuria? Oliguria and anuria. What are the definitions? And while we are at it, we'll discuss, we'll also define polyuria. What are these? Polyuria. Definitions? Anybody? Anuria, anybody? Less than 100 ml per day. Excellent, Chinmay. The anuria is less than 100 ml per day. Superb, superb answer. Oliguria would be? Okay, I'll give it away. The answer. Oliguria is 400 ml. Okay, less than 400 ml per day. And polyuria is, uh, they say actually 3 liters per day. I'm sorry, 3 liters per day or 40 ml per kg per day. This is the definition for polyuria. But if you look at the definition of anuria, no, less than 100 ml per day. So you need a day to make a definition of anuria. But here the stage 3 AKI is anuria for 12 hours. So I have always been a little confused. If you have not yet crossed up to for 24 hours, can you say it's anuria yet? What if after the 12 hours they start producing urine? Because that's a theoretical thing. And that is what I mean. Practical application of staging of AKI, I'm not sure. Maybe just to convey how severe the kidney injury is, but management wise may not make too much of a difference. Your management is still going to be the same, whether it's stage 1, stage 2, stage 3. Okay, of course, renal replacement therapy initiation means stage 3. So their management means you have already initiated renal replacement therapy. Okay, maybe before we progress, I should mention the other biomarkers. Um, yeah, okay. Before that, I'll just say you all know very well, just like how is jaundice classified? There's prehepatic, hepatic, posthepatic. How is portal hypertension classified? Again, there's prehepatic, hepatic, and posthepatic. In hepatic also there's pre-sinusoidal, sinusoidal, post-sinusoidal. Likewise, how is acute acute kidney injury classified? Pre-renal, renal, post-renal. So anything that is reducing blood flow, reduced blood flow to the kidneys, that will cause pre-renal AKI. Any damage to any component of the kidney, the component of the kidney could be the renal corpuscle, could be the tubules, could be the capillaries also to an extent. So, or the interstitium also. So the interstitium. So tubules, interstitium, or the glomerulus. Damage anywhere within the component of the kidney, the parenchyma of the kidney, or the interstitium of the kidney can result in renal AKI. Anything beyond the collecting duct, that means the renal pelvis onwards, could mean post-renal, mainly obstruction, right? Post-renal means mainly what comes to mind is obstruction. So these are the different ways to classify AKI. Okay. Just a word I'll say on certain novel biomarkers. So maybe this is not very, very important for you guys in university exams, but always good to know a few additional points about a topic. So we talked about BUN and creatinine and them having some drawbacks. Basically, they are late. Okay, they're not early. The initiation phase of any form of acute kidney injury, they may not have risen yet. Certainly, creatinine does not rise very early in pre-renal acute kidney injury because there is tubular secretion that continues. So they have some drawbacks. Currently, this is the best we have. What are the other biomarkers? Anybody? Anybody can tell me? Other biomarkers for renal dysfunction? Okay. So I'll just jot down a few. Maybe you can add on if you can. Okay, cystatin C. This, when I was doing my residency, statin C was just upcoming. It might start getting used and all. It's very, very good. It's present in all nucleated cells. So it will be a very good indicator of glomerular filtration. Very good, Chinmay said cystatin C. But the problem is even now it's not so much in clinical use. Maybe it is in developed countries, but even then, even the CKD EPI formula has formula separately for cystatin C. But then not it's not made the kind of breakthrough that we thought it will. It's very good, but somehow, I mean, it's still not found its way into routine usage. We don't routinely use it. That's still the fact. Okay, then what are the other possible uh, novel biomarkers for renal dysfunction? So there's something called neutrophil gelatinase associated lipocalin. That is again another novel biomarker. Then there's KIM1, there's 1, 2, 3. KIM1, that's kidney injury molecule 1. Then there is something called tissue inhibitor of metalloproteinase 2. Then there is something called sodium proton exchanger 3. Okay. There is, funnily, they've named it as liver fatty acid binding protein. So, liver fatty acid binding protein, though it's the kidney problem, they have named it as this. There's something else called insulin like growth factor binding protein 7. So this slightly higher point, you guys need not know it for your university exams, but still there are some novel biomarkers. There is a gap, right? I told you that you can't pick up the acute kidney injury at maybe 24 from the first 24 hours or even sometimes 48 hours. So that's where these may play a role. You may be able to make a better diagnosis if you have these kind of novel biomarkers rather than just relying on creatinine and urine output. Okay, just a mention of these, that's all. Okay, yeah, so acute kidney injury due to pre-renal AKI. Pre-renal AKI, remember, is either because of true hypovolemia or it is because of reduced effective circulatory volume. So effective circulatory volume is reduced. True hypovolemia, obviously you guys can answer this. Anybody with acute gastroenteritis, anybody with severe blood loss, severe dehydration, okay, heat stroke patients, these can end up having true hypovolemia and therefore pre-renal AKI. Remember, kidneys need 20% of the cardiac output. If the intravascular volume only is low, they're not going to get that quota, and therefore patient will end up with pre-renal AKI. Kim 1, very good. Chinmay had answered. NGAL, Kim 1, very good. Whereas, what about what could be the causes that lead to reduced effective circulatory volume? So there are certain problems. Okay, certain problems. I have not mentioned the causes. Is it okay? Causes is in the next slide. Okay, we'll come to it. But basically, there is hypoperfusion. There's compensatory mechanisms that are trying to maintain GFR, trying to maintain the urine output, but finally it fails. So that time the urine output starts coming down, and later after that, even the creatinine and the blood urea nitrogen levels and all start rising. Blood urea nitrogen may start rising early. Shailesh says dehydration. Very good. So dehydration will cause true hypovolemia. What I mean is the actual intravascular volume is fine, or even maybe on the higher side, but what is reaching the kidney? So it's like okay, um, it, it's like unfortunately our society. So the rich at the top, the country has enough money. I don't know if you'll agree or disagree. Our country has enough money. It's just that the people who are rich are having most of it, and people uh, who are not so well socioeconomically, not doing well, they don't have much of it. So, but if you pool everybody's money, India has a lot of money. So, likewise, the body has enough intravascular volume, or rather, the body has enough total body water. But what is reaching the kidneys is very less. So, renal artery stenosis, Shailesh, very good. Very good. Acute renal artery stenosis. When you're talking about renal AK, we're talking about acute. Um, if you talk about atheroembolization, I can agree. So if you're talking about atheroembolization of both renal arteries, then yes, there can be a form of reduced blood flow to the kidneys. Very good answer, Shailesh. But otherwise, conditions which either divert the blood towards other places, or the cardiac output itself is not strong enough to deliver blood to the kidneys. So, for example, in heart failure or in hepatorenal syndrome. Hepatorenal syndrome, what's happening? There's splanchnic vasodilation, peripheral vasodilation. The blood is all pooling in the peripheries, pooling in the splanchnic circulation, not enough reaching the kidneys. So that's why the patient develops hepatorenal syndrome. That means in cirrhosis, liver cirrhosis. Heart failure also, the cardiac output is just too low. Everything is stagnating in the venous circulation or in the lungs. So pulmonary edema or systemic edema, but not enough reaching the kidneys. Cardiac output itself is low. So they develop heart failure. And these are also types of pre-renal AKI. These are actually called hepatorenal syndrome and cardiorenal syndrome. So cardiorenal syndrome, hepatorenal syndrome, these are also where the effective circulatory volume is low. The kidneys don't get their quota of blood flow, though the body has enough water. Okay, and another reason why this can happen, like Shailesh said, one more reason why it can happen is if there is vasoconstriction. So afferent vasoconstriction, afferent arteriole vasoconstriction. Like for example, mm, I'll mention it here. Yeah, so these are circulatory shock. Okay, okay. I mentioned them. So hypovolemic shock, obviously. Cardiogenic shock is cardiorenal syndrome. Okay, and septic shock. Septic shock again is where the total body fluid is okay, but then the blood flow towards the kidneys is compromised. There is peripheral vasodilatation. In the early part of septic shock, there's peripheral vasodilatation, so all the blood is flowing towards the peripheries. There's a warm shock. The patient has warm peripheries, but still internally the visceral organ flow is reduced. Okay, or it could occur in hepatorenal syndrome, bilateral renal artery stenosis, like Shailesh said, acute cortical necrosis. Basically, that's because of reduced perfusion to the kidneys only. And then this. So either there is failure of the afferent arteriole to vasodilate. That means prostacyclin is being inhibited, which means NSAIDs, or the efferent arteriole is failing to vasoconstrict. So vasodilatation of the efferent arterioles, which can occur because of opposition of angiotensin 2, either via ACE inhibitors or ARBs. Okay. So there are other reasons why the afferent arteriole may vasoconstrict. Afferent arteriole vasoconstriction. Like for example, excess calcium levels, high calcium levels, or drugs like tacrolimus, cyclosporin. Okay, maybe a little too much for you guys. Just remember either true hypovolemia or reduced effective circulatory volume. That means either there is cardiac failure where the blood is pooling in the venous circulation, or in systemic venous circulation, or in hepatorenal syndrome where the blood is pooling in the splanchnic circulation or peripheral circulation. Okay, basically not enough reaching the kidneys. Okay, so this is pre-renal AKI. Just remember the term cardiorenal syndrome. That's enough for you guys. Cardiorenal syndrome. There are 5 types. Don't try and uh, you don't necessarily need to know too much about cardiorenal syndrome. Okay, basically it's because of the heart that the kidneys are not getting perfused. Try and fix the heart. That's all. That's the message. Cirrhosis also, there's splanchnic and peripheral vasodilatation that leads to renal vasoconstriction. Finally leads to HRS. HRS type 1 and type 2. HRS is very, very bad prognosis. Very, very poor prognosis. We've discussed HRS, I hope, in our cirrhosis discussion. HRS1, HRS2. HRS2 presents as, now of course, they're known as HRS AKI and HRS AKI and HRS non-AKI. Correct. So this HRS non-AKI can present as refractory ascites, whereas HRS1 or HRS AKI is very, very poor prognosis. patients will not survive without liver transplant. Be- Not more than 2 weeks. Very, very dismal survival rates. Okay. That's about pre-renal AKI. I told you about, okay, maybe in the investigations, I'll tell you more about that blood burn to create ratio and all that. Okay, renal, any damage to the components of the nephron, glomerulus, tubule, vasculature, and the interstitium, not to forget. Okay, so glomerulus, any acute damage to the glomerulus, so inflammation because of hypercellularity, that means proliferation. So all these glomerulopathies, okay, glomerulopathies. So obviously not minimal change disease. Minimal change disease, no creatinine elevation. MCD does not cause creatinine elevation. It leaves the creatinine alone, at least for the time being. What happens in MCD? What causes death in MCD? Minimal change disease. If you don't treat an MCD patient, the proteinuria will progress. Then they finally either land up with um, infections because they're losing globulins, or they'll land up with thrombosis. Okay, and only later on, if somehow they don't get affected by either infections or thrombosis, they might land up with renal dysfunction later on. But otherwise, MCD generally the creatinine levels don't rise, are not elevated. Whereas the others, like for example, membranoproliferative glomerulonephritis, or let's say mm, IgA nephropathy, all these could lead to elevated creatinine levels in an acute basis. Okay, PSGN, of course, prototypical. PSGN pathology wise, it does have components similar to MPGN, but post streptococcal glomerulonephritis. Okay, PSGN stands for post streptococcal glomerulonephritis. Sometimes good prognosis, sometimes very, very bad prognosis. PSGN can land up with rapidly progressive glomerulonephritis also. So sometimes the prognosis is a little unpredictable. MPGN can also cause it. One more entity you'll know is rapidly progressive FSGS, of course. FSGS can cause it, but you should also know something called rapidly progressive glomerulonephritis. So rapidly progressive glomerulonephritis, as the name itself suggests, it's rapidly progressive, so it's going to lead to acute kidney injury. Sometimes acute, it's called rapidly progressive renal failure also. Uh, Shailesh says antibody against basement membrane. Very good. Glomerulopathy, yes. Antibody against basement membrane. That's called, if it has the basement membrane antibodies against both the lungs and the kidneys, then it's called good pasture syndrome. So anti-GBM antibody syndrome, if it is only against the glomerular basement membrane, but if it is both lungs and kidneys, then it is good pasture syndrome. Very good answer. This that can also cause RPGN. So rapidly progressive glomerulonephritis could be caused by a variety of causes, including PSGN, including there are subtypes of RPGN also. We'll discuss that in glomerular chapter. Okay. Then there can be occlusion of glomerular capillaries, collapse of Bowman's capsule, collapsing FSGS. Collapsing FSGS is seen in anybody? Collapsing FSGS. Okay. Whenever the Bowman's capsule epithelium proliferates, no, it's not good news. When the parietal epithelium proliferates, it forms crescents. Right, parietal epithelia, when they proliferate in the Bowman's capsule, when it proliferates, it leads to crescents, and which is bad, which is something which is seen in RPGN, and where the visceral epithelium proliferates, no, it leads to collapsing FSGS, which is something seen in HIV. HIV associated nephropathy. HIV associated nephropathy. Systemic pathology is so important for medicine. True, Aniket. See, the thing is, systemic pathology is important to understand why you are seeing what you're seeing in medicine. Um, it gives you a very good foundation to not. Otherwise, it becomes a little difficult to try and add everything up. But if your systemic pathology is strong, it makes it easier. but you need not have to be disheartened if you don't remember the pathology points and all that. It's okay. A lot of medicine is basically seeing more and more and more patients. So when you see more patients, you get patterns. You start recognizing subconsciously. You start recognizing patterns. So that is more important. Experience is more important for medicine, I would say. But systemic pathology is also important to make sense of things. That's all. Okay. So any glomerulopathy could lead to an acute kidney injury. It could also lead to chronic kidney disease if it's not corrected or if it progresses little slower. It can progress very rapidly as RPGN, or it can progress little slower, like IgA nephropathy can progress very slow. Okay. So yeah. So what are the causes for glomerulopathy? Vasculitis, glomerulonephritis, thrombotic microangiopathy, malignant hypertension. All these are causes of glomerular damage that can occur acutely, leading to acute kidney injury, renal acute kidney injury due to glomerular damage. Okay. Malignant hypertension, no, when the blood pressures rise a lot, they can cause fibrinoid necrosis of the epithelia. In epithelia within the endothelium, sorry. So fibrinoid necrosis of the endothelium. Srinivas says HIV nephropathy, excellent. Collapsing glomerular nephropathy or collapsing FSGS is seen in HIV nephropathy, very correct. Malignant hypertension, fibrinoid necrosis of the endothelia. Thrombotic microangiopathy leads to something called endotheliosis. That means the edema of the endothelium within the glomerulus. Okay, but different pathologies affecting the glomerulus leading to renal dysfunction. In an acute setting. That's the glomerulus. So just remember every other cause for glomerulopathy can lead to acute kidney injury, except MCD. MCD doesn't lead to acute kidney injury. Okay. Tubular causes or damage to the tubules. What is the pathogenesis? There's going to be the tubular-glomerular feedback is going to be activated, but there's failure to resorb solutes because there's damage to the tubules, no? So there's going to be an increased luminal flow that will actually trigger off afferent vasoconstriction. So the tubules are feeling that too much of filtration is happening. So they are going to trigger afferent vasoconstriction. Whereas the problem is not too much of filtration. There's failure to resorb. There's failure to resorb solutes. They're not able to do their job. That is why the solutes are not getting reabsorbed. So the tubules, normally what should happen? The solutes should go out, get reabsorbed in the tubules. Okay, these are the tubular cells, columnar epithelia. And they're going from the lumen, they're going to exit, and therefore the feedback will go that to maintain a certain amount of filtration. Now, if the tubules are not doing their job, the tubules are all necrosed. Okay, the tubules are all necrosed. Now all the solutes will remain in the lumen only. So the flow, the osmotic effect of these solutes means the flow through the lumen is maintained. So the feedback to the glomerulus is reduce the filtration. So there's going to be vasoconstriction of the afferent arteriole. So Shailesh says renal calculi at pelvis resulting in Dietl crisis. Excellent, excellent answer. Yes, that's post-renal, but it'll be post-renal. Okay. So basically, this leads to afferent vasoconstriction. Response to vasodilators is reduced and vasoconstrictors is increased. And basic problem is there is going to be eventually that's going to lead to reduced GFR in tubular AKI. So damage to the tubules. What causes damage to the tubules? Either it is blood flow related, that means sepsis or ischemia, or direct toxins, endogenous or exogenous toxins. So what are the exogenous toxins? Drugs which damage the tubules like aminoglycosides, uh, or cisplatin, aminoglycosides or cisplatin. All these can damage the tubules. Acyclovir can crystallize. So when you're treating a patient with chicken with varicella or with herpes zoster, or let's say a patient with herpes encephalitis, if you're giving acyclovir, monitor their monitor their creatinine, monitor their renal functions. Might lead to crystal nephropathy. Can lead to acyclovir. Acyclovir. Methotrexate. Methotrexate can crystallize. You're treating a patient with Aniket says gold. Yes, gold can lead to granulopathy. Yes, it can lead to membranous glomerulonephropathy also. Gold. But we don't use gold as treatment anyway these days. In medicine, use of gold has come down. It's used by other people outside of medicine. Methotrexate is another drug that can crystallize and cause damage to the tubules. Yeah, so radio contrasts also can cause. Then there are exogenous. There's several compounds. Toxins. When you talk about toxins, ethylene glycol should come. You should remember. Antifreeze. Antifreeze is something that is used in the West. Here we use in coolants. Coolants have ethylene glycol. Um, then heavy metals, lead, uh, gold, as you said, but gold exposure is not so much. I mean, uh, ingestion of gold is not so common. Yeah, lead, unfortunately, is common. Mercury, all these can. Heavy metal exposure, cadmium, these exposures can also lead to toxins, which can lead to acute kidney injury by tubular damage. Endogenous toxins include hemoglobin, myoglobin, calcium, light chains. Light chains. Light chains means nephropathy, myeloma, multiple myeloma. Shailesh says mercury, excellent. Yes, correct. Myoglobin, yes, very good. Srinivas says myoglobin. Yes, myoglobin, yes. So I told you there are some proteins that are supposed to come into the urine, but myoglobin, hemoglobin are not supposed to. They're supposed to not be in the blood also. They're supposed to be, there should be no intravascular hemolysis, no significant intravascular hemolysis. But if there is intravascular hemolysis, if let's say a patient has cold uh, cold type of autoimmune hemolytic anemia, cold antibody, cold autoantibody type of autoimmune hemolytic anemia, or PNH, paroxysmal nocturnal hemoglobinuria, or G6PD deficiency, any cause of intravascular hemolysis. Uh, Shailesh is asking calcium is nephrotoxic. Yes, calcium is nephrotoxic by multiple mechanisms actually. First of all, calcium can lead to afferent vasoconstriction. On top of that, it can directly cause damage to the tubules. And on top of that, it can also form nephrocalcinosis. So it can deposit within the nephrons. So it is via multiple mechanisms, calcium can end up leading to renal damage. In fact, in multiple myeloma, the main reason for the renal dysfunction in myeloma is calcium, followed by light chain nephropathy. So calcium is the main thing that is the problem in myeloma. Srinivas says bilirubin salts. Yes, even bilirubin has an influence in being an endogenous nephrotoxin. Very correct. Very true. Shailesh says malaria. Very good. Yes, malaria also. There are certain infections. So when you talk about infections which can lead to renal damage, malaria definitely. HIV already we spoke about. Uh, HIV is a little more more chronic rather than acute. So HIV, I'll leave it out for now. Malaria, yes, acute kidney injury. Renal, then leptospirosis. Um, Pyelonephritis directly, if there is an infection within the kidney parenchyma itself, acute pyelonephritis, that itself can lead to Legionella. Legionella, although it's causing pneumonia, yet they can end up developing renal dysfunction, acute interstitial nephritis, tubulointerstitial nephritis. That's what it causes, Legionella. Apart from leptospirosis. Leptospirosis we already discussed. How will the leptospira spread? It has to spread through the urine only. Okay, so that is why it will force a non-oliguric renal failure. So the kidneys will first there's inflammation in the kidneys, and that will allow the bacterium to be excreted, and then from there it will try and find a new host. Right. So these are all different infections, toxins, endogenous toxins also. Very good answers. Very good answers. SLE. Shailesh says SLE. Yes, true. It can cause RPGN. SLE can cause RPGN, therefore lead to acute kidney injury. via multiple mechanisms. Either it can lead to tubular damage, tubulointerstitial damage. It can maybe I'm not. Oh, it's here, right? So yeah, pyelonephritis, Legionella, it's all here. Infiltration, leukemia, lymphoma, that's rare. Rather, leukemia, lymphoma, leukemia especially post chemo, no? Post chemo, there can be uric acid. I didn't mention that. Uric acid is also an endogenous nephrotoxin, especially when tumor cells die at the same time. Large tumor burden cells die at the same time because you gave chemotherapy. All the tumor cells died at the same time. All the intracellular uric acid gets released. That leads to uric acid nephropathy. That's something called tumor lysis syndrome. Tumor lysis syndrome. So you have to try and prevent this. If you know that the patient has a large tumor burden, especially tumors like leukemias, like AML. AML, no, the total leukocyte count maybe like 2 lakh, 2.5 lakh and all that. Yeah, astounding numbers. So in that case, all those tumor cells, if you give chemo, all of them will die and liberate a lot of uric acid, and that can lead to renal dysfunction. That's called uric acid nephropathy. Actually, uric acid nephropathy. The other name is tumor lysis syndrome. Both are the same. Uric acid nephropathy or tumor lysis syndrome. You have to prevent this by giving allopurinol and hydration, adequate hydration. Inflammatory conditions like Sjogren's, antibiotics. Yes, what are the antibiotics which can lead to acute interstitial nephritis? So this is interstitial we're talking about. Acute interstitial nephritis, antibiotics, rifampicin, cephalosporin, um, sometimes even sulfonamides, quinolones to an extent can cause interstitial nephritis. But otherwise, rifampicin very well known to cause it. Acute interstitial nephritis, subacute interstitial nephritis usually rifampicin. And apart from all these, NSAIDs can cause interstitial nephritis, allergic interstitial nephritis. They may be eosinophil in the urine in allergic interstitial nephritis. Okay, it's extensive actually. The list is extensive. Unfortunately, in acute kidney injury, the discussion is mainly on what's causing it and uh, how how should we have prevented it or how can we prevent it in the next patient, because treatment is trying to reverse the cause and supporting the kidney in the form of renal replacement therapy. Yeah, the list of drugs which can cause acute kidney injury: aminoglycosides, rifampicin, penicillin, yes, amoxicillin. All these can cause acute interstitial nephritis. Amphotericin B, oh, that's notorious to produce renal dysfunction. Amphotericin B can also lead to type 1 RTA, type 1 RTA, renal tubular acidosis. Okay. Mm. Acyclovir, I already told you. Indinavir, that's a protease inhibitor. This can also cause, in the last class for HIV, we would have discussed about tenofovir, no? Tenofovir diproxyl fumarate, TDF, can lead to acute kidney injury. Okay. Cisplatin, tubular damage, phenytoin, it can lead to, yeah, if it can lead to interstitial nephritis, phenytoin. But otherwise, not very common though. Okay. So all these are drugs which can lead to acute kidney injury. Some of them we very commonly encounter, like acyclovir, very common. Uh, NSAIDs, of course, amphotericin B. All these are common causes of drug-induced acute kidney injury. Post-renal, amphotericin B, very good, Srinivas. Amphotericin B, if you're treating a patient with uh, mucormycosis, but other than that, more commonly, if you're treating a patient with cryptococcal meningitis, HIV patient with cryptococcal meningitis, you're giving amphotericin B with the flucytosine. You have to monitor the creatinine. You have to monitor the urine output. Though the urine output is generally preserved, the creatinine starts going up. Okay, now there are liposomal preparations which reduce the chances, but still it still happens. Renal acute kidney injury, RTA can happen. Renal tubular acidosis, type 1 RTA. Okay, post-renal causes. If it has to cause an acute kidney injury, it has to produce bilateral obstruction, which means more likely to occur either at the level of the bladder or the urethra. Bladder or urethra. Correct? If both kidneys, the flow has to reduce, the obstruction must be at a common point. Otherwise, let's say this is the kidney. This is one kidney, this is the other kidney. If the obstruction, this is the bladder, and this is the urethra. So if the obstruction was here, then the other kidney could still compensate, right? So you wouldn't necessarily have a gross reduction in urine output or gross elevation in creatinine. So an obstruction here or here would be more likely. So hydronephrosis, very, very correct, Shailesh. So something that is, if it is an acute event, then it must be something here or here. Okay, so a lot of times what happens, elderly patients will come. Okay, let's say an old man, let's say a 75-year-old man came to you saying, I have rhinitis, I have running nose, I have blocked nose, I have throat pain, give me something. So what you'll do, you'll give them, either you'll give them antihistamine. Okay, by chance, if you give them first generation antihistamine, chlorpheniramine, you give them off. Or you'll give them a combination. Okay, you would have heard of some of these combinations. We also prescribe them. But what maybe you would have heard of Alercet cold, uh, D cold total, like that. Some of these ads and all used to come. So you give them these. What will they contain? They'll contain something like pseudoephedrine or phenylephrine. So which means these are sympathomimetic drugs. So sympathomimetic drugs or drugs with anticholinergic effects. Okay, first generation antihistamines like chlorpheniramine. You give them the cold medicine, and you might not have asked. You wouldn't have the presence of mind. You can't keep asking everybody everything. That's what you should be doing. But sometimes you miss it. So you wouldn't have asked, do you have BPH or do you take medications for BPH? Do you have any urinary trouble at all? If you don't ask this and you give them this cold medicines, they may it may precipitate bladder outlet obstruction. Okay, so somebody who develops acute retention of urine, an old gentleman uh, who recently was given medications like these, anticholinergic or sympathomimetics, what will that do? It might precipitate a bladder outlet obstruction. So they might develop acute retention of urine that can lead to acute kidney injury. So a practically encountered problem. Okay, so you have to be careful. Elderly people, anyone above 50 for that matter, any man above 50, ask them any trouble in passing urine. Nocturia is there. You pass frequently in the night. Do you have poor stream? Do you have dribbling of urine? If so, then you be careful when you give them medications for cold or anything that might precipitate bladder outlet obstruction. Okay, nonetheless, because of obstruction, there's increased retrograde pressure and reflex afferent vasoconstriction. I have not mentioned. Okay, or if it has to be ureteric obstruction, it has to be bilateral. Neurogenic bladder, that's one thing you have to keep in mind. Like for example, a patient who develops acute transverse myelitis, no, they'll have neurogenic bladder, hypertonic bladder. That can lead to acute kidney injury if it's allowed or if it's not corrected, if it's not detected, if the patient is not catheterized in that case. Okay, BPH stricture is usually not acute, but possible that it can lead to acute kidney injury. Okay. Yeah, before we go to that, you should also remember something called mm, papillary necrosis. What are the causes of papillary necrosis? One of my students told me this mnemonic, which I'll tell you guys. Soda is the cause of papillary necrosis. Okay. A is mellitus. O is okay. So papillary necrosis is again another form. Okay. Anyway, hopefully Can you guys hear me? Chinmay, can you hear me? Devashish? Okay, thank you, Chinmay. Yeah, uh, correct, Srinivas. Internal sphincters have alpha receptors, alpha 1, no? Uh, if you're going to alpha 1, sympathetic is always to try and make sure that you're uh, you're ready for running. That's what sympathetic is for. If you want to start running, you need your sympathetic stimulation. So while running, you don't want to be passing urine, you don't want to be passing stools. So that is why sphincter alpha 1 receptors on the internal sphincters, urethral sphincter, will try and constrict it. So if you are going to promote sympathomimetics, you're going to promote that alpha 1 receptor, you can lead to retention of urine in a patient who has BPH. Okay. Not so much in pre-renal. Okay. That is one. And then non-oliguric acute kidney injury could be seen in conditions like acute interstitial nephritis, partial obstructive nephropathy, Dietl syndrome, like uh, one of you had told, Dietl's crisis. Shailesh has only said that. Yeah, acute tubular necrosis could lead to non-oliguric acute kidney injury, especially in the diuretic phase. So initially there'll be an oliguric phase followed by a diuretic phase. In the diuretic phase, and radio contrast induced acute kidney injuries. That's why you have to monitor the creatinine 48 hours after the contrast exposure, not immediately. Generally, this prognosis is good. Okay, radio contrast induced nephropathy. The prognosis is good. By the end of the week, no, in generally most patients their creatinine will return to baseline. You don't have to intervene in the form of renal replacement therapy or any additional support. Just make sure that they're hydrated and monitor mainly tubular toxicity. So anything that targets the interstitium or the tubules, not the glomerulus, will spare tubules. Sorry, tubules will spare the filtration function. Therefore, GFR will be maintained. Non-oliguric acute kidney injury. Onset anuria. What conditions can you get? Sudden onset anuria. Severe shock, bilateral renal artery occlusion. At the same time, it's not very common, not at all common. Tubular necrosis, acute cortical necrosis. Acute tubular necrosis also in oliguric phase. So total obstruction, like a neurogenic blood clot, acute transverse myelitis. Okay, so these are causes of anuric acute kidney injury. I have not mentioned causes like HUS and TTP. Okay, TTP, HUS can lead to total anuria out of the blue. Pregnant lady after delivery not passing urine, creatinine rising, and hemoglobin dropping, platelet dropping. You do a peripheral smear, the schistocytes. That means the patient has developed HUS TTP. Okay, one of the examples. One of the examples I had encountered. So you can have total anuria all of a sudden out of the blue. Okay, acid-base balance, Kussmaul's breathing because of acidosis. We had a patient, HIV patient, who had persistent loose stools, landed with acidotic breathing, hypovolemic shock. So, combination of high anion gap metabolic acidosis and non-anion gap metabolic acidosis. The NAGMA was because of diarrhea, and the high anion gap metabolic acidosis was because of hypovolemic shock, lactic acidosis. Okay. Yeah, uremic bleeding, encephalopathy. These can also occur. So these are uremic features: uremic encephalopathy, uremic bleeding, uremic pericarditis. Um, yeah, uremic bleeding, pericarditis, encephalopathy. These are uremic features. Okay, what are the investigations in acute kidney injury? Obviously, nitrogenous waste, blood, urine, nitrogen, creatinine, uric acid, much more preferred, rises more in pre-renal, and the other two forms, creatinine will rise more. The ratio is important. Have I mentioned that? No. Okay. So blood urea nitrogen to creatinine ratio will be more than 20 if it is pre-renal. Okay, okay. Whereas in renal, the ratio will be less than 20. It's not very strict. Okay, it has good positive predictive value. But it's not. It doesn't exclude. So just because the ratio is less than 20 doesn't exclude a pre-renal AKI. If it is there, it definitely helps you to make a diagnosis of pre-renal AKI. But just because not there doesn't rule out a renal AKI. Okay, I think there's a slide on pre-renal versus renal. I'll come to that. Mm, okay, investigations, GFR measurement, DTPA. If you really want to do it, you can do it. Otherwise, you calculate the creatinine clearance. That also really, these are dynamic changes. No, you try and correct the cause unless you are worried about drug dosing in elevated uh, renal dysfunction. Uh, Farhan is asking clinical significance of serum uric acid. Uh, it's not specific. That is the problem. Uric acid is also not specific uh, for renal function. It will usually remain. It may get elevated. See, it's also absorbed in PCT. So if there's a PCT dysfunction, you can get uh, elevation in uric acid level. But at the same time, high uric acid level can also damage the kidney. So this also leads to the other way around is also correct. So it's called uric acid nephropathy, which is seen in tumor lysis syndrome. So you can't base it's not a great parameter for making a diagnosis of uh, renal dysfunction. Farhan's from Pakistan. Hi. Uh, but that's the thing. It's not very specific for renal dysfunction, but it is important to an extent. There are other reasons why uric acid may be elevated. No, so many other reasons, unfortunately. So dietary. So if there's a high purine intake, so uric acid is basically a purine derivative. No, so if there is a high purine diet, hemolysis syndrome, very correct, Farhan. High organ meat. Okay, so organ meat generally has a lot of high purine content. Or certain drugs can lead to high uric acid levels. The other day we had a patient who was on cyclosporin. Uh, I forget the indication why the patient was on cyclosporin, but the cyclosporin had pushed up the uric acid in that patient to 13 milligram per deciliter. So we had to, and like that. So drugs can push it up. Though the kidney, in her case, in that patient's case, the renal dysfunction was not there. So uric acid had gone up without renal dysfunction. Though cyclosporin can cause renal dysfunction also. So that's why, not very specific, unfortunately. Yes, very good. Ethambutol, pyrazinamide, both of them can cause ATT drugs. Absolutely correct. Pyrazinamide, ethambutol, both can elevate uric acid levels. So without necessarily causing renal dysfunction. So not as specific as creatinine. When the creatinine rises, there's almost no other reason apart from apart from a renal dysfunction, whereas the other way around is not so accurate. So there may be renal dysfunction without yet there being an elevated creatinine. So since there is a lag, there is a gap. That is the problem. So how to address that problem? We are still working at it. We don't have great options. There are novel biomarkers which I discussed, but then practically not yet in use. Okay. This, if you really want to measure the GFR, you can do the creatinine clearance. Otherwise, uh, you can just try and address the cause. Yeah. So fractional. Okay. Blood urea nitrogen creatinine ratio of more than 20. Good positive predictive value for pre-renal AKI. Okay, these are all parameters which suggest pre-renal AKI. Fractional excretion of sodium being less than 1%. So the body is trying to preserve sodium. Sodium is good for maintaining intravascular volume. So already if there is volume loss, non uh, uh, okay, I forgot to tell you diuresis. So diuresis, diarrhea, and dehydration. These are the causes of um, volume loss. Dehydration should include blood loss also. Okay, blood loss, acute blood loss. So all these are causes of hypovolemia, true hypovolemia. So except for diuresis, the excretion of sodium in prerenal AKI will be less than 1% because the kidney is trying to preserve sodium to try and maintain intravascular volume in prerenal AKI. So your fractional excretion of sodium will be less than 1%. Your actual urine sodium will also be low. Urine sodium, if you measure, will be less than 20 milliequivalents per liter. Okay, so low urine sodium, low fractional excretion of sodium. These are suggestive of prerenal AKI. Oh yeah, I mentioned here. Okay, hyaline casts. Yeah, bland casts. These are bland casts. So bland casts. These are just TAM phosphol proteins. Hyaline casts are just TAM phosphol proteins, which are normal proteins in the tubules, tubule components. So that again suggests nothing in the kidney. It's pre-renal, like that. Specific gravity of the kidneys being, I mean, of the urine being high, the osmolality being high, all these would suggest. Okay, there's something called fractional excretion of urea also. I told you, urea gets reabsorbed, no? So less than 35%. Less than 35% fractional excretion of urea is again suggestive more towards pre-renal AKI. Okay. Good positive predictive value for all these. Don't don't rely on these, just these, because if these are absent, doesn't rule out a prerenal AKI. Fractional excretion of sodium. It's not a very commonly used test. Instead, you can just directly send for urine sodium. Urine sodium itself will give you an idea of whether it's, if it is less than 20 means more likely to be prerenal AKI. Renal causes glomerular RBC casts. Very important. RBC cast would suggest. RBC cast means from where has the RBC come? It has come, somehow it has gained entry into the tubules, right? So if the RBC was present in the tubules only, it will mix with the TAM phosphol protein and come out in the urine as RBC casts. So if you are finding RBC cast, or if you're finding crenated RBCs, dysmorphic RBCs, crenated RBCs, then you will be able to say that the RBC has come from within the tubules, which means it has come through the glomerulus. How else would it gain access into the tubules? It has come through the glomerulus. So glomerulopathy, RBC cast would be a glomerulopathy, or a dysmorphic RBC would mean glomerulopathy. As the RBC is trying to pass through the glomerulus, it will become dysmorphic. It will become crenated. The shape will change. So that indicates it's a glomerulopathy. Farhan's asking intracellular hemolysis. I'm sorry. Uh, how we differentiate between acute tubular necrosis and acute cortical necrosis? Tubular necrosis, that's the thing. Generally, it will pass through those phases, the oliguric and then the diuretic phase. And you can see muddy brown casts also. So when you look for the urine, when you examine the urine after centrifugation, you might be able to make out certain clues like muddy brown casts in the urine. Cortical necrosis, it's like there's not going to be any urine output, and there's not going to be any diuretic phase also, if it is bad enough, acute cortical necrosis. So they'll just have a very low total stoppage of urine output. The creatinine starts rising quite fast. So it's a little more severe than acute tubular necrosis. Tubular necrosis has a good reversibility. Cortical necrosis, not great. Intracellular hemolysis. No, yeah, that's also correct. Not intracellular, but at this junction. So as they're trying to, normally the glomeruli are supposed to not allow RBCs to pass through. RBCs are so much bigger than these podocyte, the glomerular filtration barrier. The space between the foot processes of the podocytes is not at all enough to allow RBCs to pass through. But if it is passing through, means there's a significant damage here in the glomerular filtration barrier, and that is why the RBCs are now passing through. So if you're saying RBC cast or dysmorphic RBCs, it's a glomerular damage, glomerular issue. Okay, or proteinuria more than 1 gram per day. Actually, more than one glomerular proteinuria is said to be at least more than 2 grams, 2 grams per day. I should make this 2 grams. Okay, up to 1 gram, even tubular proteinuria can be there. So proteinuria can be glomerular or can be tubular also. Tubules also can lead to, if there's a tubular pathology or a tubular interstitial pathology also, there can be proteinuria, but that will never exceed 2 gram per day. If it is more than 2 gram per day, it is most likely a glomerular pathology. Okay. Mm, yeah. Tubular pathology, you'll see granular casts in acute tubular necrosis. WBCs may be visible. WBC casts may be visible. Okay, especially in acute interstitial nephritis. Acute interstitial nephritis, WBC casts. Eosinophil can be seen in acute interstitial nephritis or atheroembolic disease for that matter. Uh, there's a lot. Okay, osmolarity will be generally low because nothing is getting reabsorbed. Fluid is also being lost because of the solutes being lost. So it will be dilute urine, low osmolarity. Okay, that's what you see in urine. Post-renal radio imaging is important. You have to find out where is the level of obstruction. Is it in the at the level of the ureter? Unlikely if it is acute kidney injury, bilateral ureteric obstruction, or is it in the bladder, or is it in the urethra? So intravenous urography or pylography, CT or MRI of the kidney, ureter, and bladder, and ultrasound abdomen, pelvis with post-void residual urine. Post-void residual urine. Okay. That's what you'll do as investigations for post-renal. Treatment in acute kidney injury, reverse the cause. Okay, if it's pre-renal hypovolemia, whether true hypovolemia or reduced effective circulatory volume, correct it. Try and correct it at least. Sometimes, like for example, in HRS, there's not much you can do unless you can arrange for liver transplantation. Or let's say in refractory heart failure also, unless there's cardiac transplantation, there's limited options. But at least whatever you can correct, you try and correct. Treat the cause, maintain fluid, electrolyte, acid base balance. Try your best to maintain, to try and negate the ill effects of renal dysfunction, acute kidney injury. Okay. Pre-renal, maintain volume. If there's blood loss, arrange for RBC transfusion, packed RBC transfusion. Crystalloids for the volume loss, albumin in HRS. Okay. In hepatorenal syndrome, prevention and treatment, albumin. You can use other agents also, of course. You can use or you can use octreotide, you can use midodrine with norepinephrine. You can use terlipressin. These are other agents you can use in HRS treatment. Okay, terlipressin, then midodrine, plus norepinephrine. Okay, crystalloids. So isotonic fluids like normal saline you can use to try and maintain hydration. Okay, that's pre-renal. Renal glomerular immunosuppressive agents. You see what the cause is. If it's PSGN, you don't even need to give steroids. You just, unless they're going into RPGN, you can just try and supportive treatment should be enough. ACE inhibitors. Yeah, ACE inhibitors are mainly meant for CKD. Or if they are not having, like for example, MCD, minimal change disease with only proteinuria and no elevation in creatinine, then you can use ACE inhibitors. Otherwise, they are not appropriate for renal AKI. That's the wrong. This is not correct. ACE inhibitors are not used for treatment of AKI. ACE inhibitors are contraindicated in AKI. ACE inhibitors slow down progression of CKD, but they are contraindicated in AKI. Acute kidney injury, when the GFR is varying, fluctuating, dynamic changes in GFR, do not give ACE inhibitors or ARBs, even if there's proteinuria, will do more harm. Okay, your potassium may start rising and it might be fatal also. So no ACE inhibitor ARB in acute kidney injury. CKD, yes. Chronic kidney disease, very, very useful. Very, very useful. ACE inhibitors and ARBs, especially when there's proteinuria. Sorry, where did it go? Yeah. So otherwise, if there's tubular, so because they are going to go through this polyuric phase, no, or diuretic phase. In the diuretic phase, they may end up having, as well as in oliguric phase. Oliguric phase, what happens? Very often they'll have hyperkalemia, whereas diuretic phase they have hyponatremia. Okay, and sometimes even hypokalemia. So you have to correct the electrolyte disturbance in acute tubular necrosis. Fluid balance also, diuretic phase. Even in oliguric phase, they'll have risk for pulmonary edema, risk for cardiac failure because of increased intravascular volume, reduced excretion. That's why acute tubular necrosis. Okay, so watch the fluid, watch the electrolytes. Post-renal, relieve the obstruction. Okay, that's the surgeon's job. So I will call Kishan sir to come and relieve the obstruction for a patient with post-renal acute kidney injury. Okay, if you are or what you could do, you could try and go for a suprapubic catheterization. So suppose there's an acute retention of urine at the level of the bladder outlet, so bladder outlet obstruction or a urethral obstruction, then you can go for a suprapubic cystostomy and catheter insertion. Okay, renal replacement therapy, hemodialysis, acute peritoneal dialysis, renal transplantation. Renal transplantation is for rapidly progressive renal failure. I told you cortical necrosis. Acute cortical necrosis, the patient's kidney functions may never reverse. Okay, HUS TTP, it may never reverse. The patient lands in renal function failure, and the renal functions never go back. Very unfortunate, not very common, but implantation. Okay. RPGN. If they survive the RPGN, then they may not have enough renal functions to continue without RRT, without renal transplantation. So even in acute kidney injury, if it leads to rapidly progressive renal failure, it will warrant transplantation also eventually. Okay. Acute peritoneal dialysis very, very rarely performed. We used to see it when in our residency, because in resource poor settings, it's an option, very temporary option. Otherwise, best thing is to do the hemodialysis. Okay. What are the indications for hemodialysis? Have I mentioned that? Yeah. Indications for hemodialysis. Uh, what are the indications? Which of these is not an indication? So these is not an indication for hemodialysis. Refractory volume overload, definitely an indication. Hyperkalemia, definitely an indication. But it has to be refractory, of course. It has to be refractory hyperkalemia. Refractory metabolic acidosis, yes. Uremic pericarditis or encephalopathy, yes. So actually the answer would have been plain hyperkalemia. So just because the potassium is high, your first instinct is always medical therapy. How do you reduce potassium levels medically? What do you need to do? Remember, if you see some patient has high potassium levels, yes, very good, Farhan. Treatment failure, high potassium levels despite medical therapy. So what will you give? Remember 10, the rule of 10 for potassium. 10%, 10 ml over 10 minute is calcium gluconate. But calcium gluconate does nothing to potassium. It is only stabilizing the cardiac membrane to prevent arrhythmias. Other than that, you give 10 milligrams of albuterol. Albuterol is what? Salbutamol. Actually, albuterol in US they call it as albuterol, but it's just salbutamol. But you have to give 10 milligrams. Okay. Usually it's available as 2.5 milligrams respules or 5 milligram respules. That is for bronchodilation. But here you're not giving for bronchodilation. You're giving it for reducing potassium levels. So you need to give a higher dose. 10 to 20 milligrams also you can give. But just as a rule of 10, you can remember 10 milligrams. And you have to give insulin, 10 units. 10 units of insulin. If the sugars are high, you don't even need to give anything else. Just give insulin IV. IV. If your sugars are normal, then you mix it with 25% dextrose. Okay, so remember rule of 10 for hyperkalemia. Calcium gluconate, 10%, 10 ml over 10 minutes, 10 milligrams nebulization of albuterol, that's salbutamol, and 10 units insulin, plus or minus dextrose. That is your immediate medical therapy. Apart from that, bicarbonate plus or minus, if the patient also has metabolic acidosis, give bicarbonate. That also reduces potassium levels. If none of these are working, you have to go for dialysis. Refractory hyperkalemia. Farhan has asked for dialysis disequilibrium syndrome. Fortunately, these days, I don't think at least I've not come across in a very, very long time, dialysis disequilibrium syndrome. What happens in dialysis disequilibrium syndrome? Newly initiated, you patient has, let's say, never undergone dialysis naive. Okay, now patient had a lot of solutes in the blood. Because of renal failure, all the solutes had accumulated, all their urea and nitrogenous wastes, all that had accumulated. Now you subjected them to dialysis. Now, during dialysis, what happened? all the solutes came out into the dialysate, and now the blood has become totally solute free. That means the osmolarity has dropped. No, here there was hyperosmolarity. Now the osmolarity has totally gone down. When the osmolarity suddenly drops, what happens? What should the fluid do? So you took out the solutes, but you didn't really take out the fluid. Fluid has stayed back in the blood. Now that fluid may shift into other spaces, especially the brain. So if you have a sudden shift of fluid into the brain, that can cause cerebral edema. Cerebral edema. So that might result in dialysis disequilibrium syndrome. So technically, you need to give osmotic diuretics like mannitol for treatment of dialysis disequilibrium syndrome. But mannitol is not going to work when the creatinine is when the GFR itself is low. In fact, it may be dangerous to give mannitol when the creatinine is or when the urine output is low. You're dialyzing the patient, probably the urine output is low. So in that case, giving mannitol is also very tricky. But it's anyway in general not common now in dialysis. The technique of dialysis has improved so much that disequilibrium syndrome is not very common. But it is a side effect. It is, in fact, it used to be one of the most common side effects. Even now, mild forms may occur, but never bad enough to warrant any real treatment. They settle. Most common side effect of dialysis is probably just chills, and uh, they'll experience a little bit of fever initially because of cytokine release during the dialysis and all that. But otherwise, dialysis is generally safe only. And of course, hypotension. Hypotension can occur if very vigorous dialysis is done and sudden shift of suddenly a large volume of fluid is removed. Only then. Okay. Yeah. So what are the differences between pre-renal and renal AKI? Clinical hypovolemia is present in pre-renal. FENA is less than 1%. It's more than 2% actually. More than 2%. Sorry, more than 2% in renal AKI. Urine osmolarity is high, low. Urine sodium is low, high. The ratio of 1 to creatinine more than 21 and less than 20:1. Okay. Even fractional excretion of urea less than 35, more than 35%. That's another difference. Okay. Already stretched for quite a long time. I still have. I just chronic kidney disease. I'll try and finish in little quickly. Okay. One very very important message is it's never a reversed cause of acute kidney injury. Though we say the acute kidney injury has reversed, not a true statement. It's only been compensated because any acute kidney injury means there has been some loss of nephrons. So the surviving nephrons are somehow compensating, but it can take a toll on the surviving nephrons, which may reflect in chronic kidney disease in the future. The patient may develop chronic kidney disease in future. So any patient who develops acute kidney injury, it just means that their renal reserve is low. And that's why the acute kidney injury has manifest. And therefore, in future, if there are other insults, let's say the patient goes on to develop diabetes or the patient goes on to develop exposure to nephrotoxic uh, nephrotoxins, then they can develop CKD earlier than somebody who's never had an acute kidney injury. Okay, so it's never truly reversed. It's just a warning that there may be a future risk of CKD. Okay. Yeah. Chronic kidney disease. Shailesh says glomerular hyperfiltration. Excellent answer. That is absolutely correct. So surviving nephrons, they're trying to maintain GFR by hyperfiltration. So that hyperfiltration will take a toll. Actually, you guys know about cardiac remodeling, no? Cardiac remodeling. What's happening in cardiac remodeling? Heart is there. It's normal. First, it's normal. Then there's an insult to it. Because of that insult, EF reduces. I'm just giving an example. There can be preserved EF also. Basically, there's heart failure. Let me put it as heart failure. So initially, there's heart failure, acute heart failure. In acute heart failure, there's going to be compensation. What compensation? There's going to be an increase in intravascular volume, increased intravascular volume, and increased inotropicity. What does these two things? Okay, intravascular volume is increased by angiotensin 2 by acting on aldosterone. So angiotensin 2, RAS, basically renin angiotensin aldosterone mechanism system. Okay, RAS will try and increase the intravascular volume. At the same time, inotropicity is also increased because of sympathetic activity. Very good, Shailesh. Hypertrophy. Hypertrophy is a chronic thing. Okay, in acute heart failure, these two are trying to maintain compensation. So in an acute setting, this is excellent. But if this continues, no, the patient lands up with chronic heart failure. Sorry, chronic heart failure. And chronic heart failure, these are not good influences. They will result in LV remodeling, left ventricular remodeling, which includes hypertrophy, like Shailesh has said. So LV remodeling is not a good thing for the heart, because LV remodeling means the muscle cardiac myocyte is being replaced with non-contractile structural proteins, including fibrosis. There's going to be fibrosis also. Increase in heart rate, Srinivas said. Yes, increase in heart rate, especially in acute heart failure. That's the effect of inotropicity, chronotropicity, sympathetic activity. But over the period of time, over longer period of time, it leads to remodeling, which is bad. So how do you prevent this remodeling? You give drugs which oppose sympathetic system, like beta blockers. You give drugs which oppose RAS. So you oppose the angiotensin, that means ACE inhibitor ARB, and you oppose the aldosterone, that means mineralocorticoid receptor antagonist. Very similar concept is with kidneys. What's happening? Kidney. Initially, some insult. It's acute insult. So acute kidney injury, let's say it's acute kidney injury. Okay. How do you compensate for that? There's going to be, like Shailesh says, some nephrons have died. Let's say out of 100 nephrons, 10% have died. So now only 90 are surviving. So the rest of the 90 will somehow increase their GFR by increasing their glomerular filtration pressure and maintain the GFR. Okay, so individual GFR, if it increases, it will match the 100 nephron GFR. What is allowing this to happen? It is angiotensin 2. So angiotensin 2 is producing renal efferent arterial vasoconstriction, maintaining GFR. But in the acute setting, it's excellent. In the chronic setting, what's happening? Because of increased GFR, there's going to be sclerosis of the glomerulus. So thickening and sclerosis of the glomerulus will happen. And that means the glomerulus is thick. And if it's thick, it cannot allow filtration to occur normally, because it's constantly hyperfiltration, constant pressure, constant trauma. It can't deal with it for too long. So the GFR will start declining. So it can lead to CKD. So how do you prevent this CKD? You give them ACE inhibitor ARB. So again, angiotensin 2 was mainly responsible for it. So you give them ACE inhibitor ARB. So very similar to heart failure, where acute to chronic problem was remodeling. You needed to give ACE inhibitor ARB. You need to give all the other drugs also. You should notice even SGLT2, even mineralocorticoid receptor antagonists, except maybe beta blocker. Beta blocker is one drug that generally doesn't have too much of benefit in CKD, unlike in heart failure. But other drugs are overlapping. Like mineralocorticoid receptor antagonists also reduce progression of CKD. SGLT2 inhibitors reduce progression of CKD. ACE inhibitor ARB reduce progression of CKD. Similar concept. They reduce this remodeling of the kidneys. Okay. So that concept is similar between heart and kidney. Okay. Otherwise, yeah. What is the definition? Abnormality of kidney structure or function present for more than 3 months with implications for health. Funnily, no. One thing I'll tell you, estimated GFR. I told you estimated GFR is used for CKD, not for AKI. There are two main ways you can define CKD. Either they have reduction in GFR or they have albuminuria. I told you preserving albumin, preserving proteins is an important function of the kidneys. Generally, albuminuria is not used for defining AKI. Urine output is used for defining AKI. Creatinine is used for defining AKI. But for CKD, creatinine is used indirectly as EGFR. We use creatinine-based formulae for determining EGFR. But urine output is not used. Instead, albuminuria is used. Okay, so albuminuria or reduction in EGFR will define CKD. Okay. Um, yeah, so it has to be present for 3 months. So timing is important. Acute, we discussed acute timing, no? 48 hours, 7 days. Sorry, 6 hours, 48 hours, 7 days. 6 hours urine output, 0.5 ml per kg per hour. 48 hours is creatinine level elevation by 0.3 milligram per deciliter at least. Or 7 days is 1.5 times of baseline creatinine. Here, the chronic term is for 3 months. Okay. So when I talk about EGFR, how much EGFR should have reduced? Sir, explain. Srinivas is asking acute on CKD. Acute on CKD is already renal function. Basically, it's like acute hepatitis on chronic hepatitis, like that. So already the renal function has reduced. There's renal dysfunction. On top of that, there's an acute event, acute stressor. So usually, most often, if there is an acute on CKD, the acute point will be either dehydration or drugs, something that produced an acute reduction in, like a COPD exacerbation, similar to COPD exacerbation. In COPD, already the lung functions are reduced. During an exacerbation, it reduces even further. Why? Because either an infection or let's say a patient develops exposure to some irritant, like that. Likewise, in acute on CKD, there's an acute factor like sepsis, like an infection, okay, systemic infection that deprives the blood to the already dysfunctional kidneys. So just a fresh insult, an acute insult for already chronic kidney disease. Uh, Aniket is asking, CKD should not be defined with serum creatinine. Correct. Serum creatinine you can't define, but you can calculate the estimated. You can estimate the glomerular filtration rate using the serum creatinine, and then see if the patient fits into CKD. If CKD, then what stage of CKD, what grade of CKD, like that. So it's not used for defining directly, but indirectly using the EGFR. So EGFR formulae are based on creatinine. There's an EGFR formula based on cystatin C also, but that's not commonly used, not in India at least. I don't think it's used so much in the West also. Dengue infection, Shailesh says yes. So any infection can cause acute on CKD. So, like I said, urine output definitely no role in defining CKD, unlike in AKI where urine output and creatinine are very important. Here it's EGFR and albuminuria. So yeah, as I was saying, how do you estimate GFR? There are different formulae, uh, very very old ones like Cockcroft-Gault. That was there when I was studying MBBS. Cockcroft-Gault formula was being used. Then from there it shifted to MDRD. When I was in PG, it was MDRD. I just finished PG, then CKD EPI came. Then the latest CKD EPI formula is 2021. So 2021 CKD EPI formula. You don't have to know the actual formula. You can just use any of these apps online. MD Calc is a very, very good application where you can just enter the values. So, but it does depend on serum creatinine. So, like Srinivas was saying, sorry, Aniket was saying, serum creatinine doesn't directly help in staging the CKD. After estimating the GFR using this formula, you can stage the CKD and define. In fact, for defining CKD, wait, I'll come to that. Here's the cystatin C based one. Okay, so it's a combination of creatinine and cystatin C. Both are required, but not very commonly used. Just remember the name of the formula and the latest version, that's 2021. Okay, and that is what is used. Okay, please do not make the mistake. I see sometimes our students use Cockcroft-Gault, sometimes they use MDRD, modified diet in renal disease. That was MDRD was. That was during my residency time. It was like 12, 13 years ago. Okay, now it is CKD EPI, and that too in that 2021. it's very sensitive. CKD EPI is sensitive for lower GFRs. Um, Generally, it can overestimate GFRs a little bit in South Asians. South Asian population EGFR is little overestimated by that CKD EPI formula, but nonetheless, that's the best we have right now. Remember, the creatinine has to be stable if you're trying to apply EGFR formulae. Now, this is the grading or the staging of um, CKD. I'm sorry. So either you grade it according to the EGFR or you grade it according to the albuminuria. Okay. Terms are important. Terminologies are very, very important. See, earlier we used to use the albumin excretion of 30 to 299 milligram per day as okay. This is urine albumin creatinine ratio, but it's the same as it's equivalent to per day excretion. So 30 to 299 milligram per day urine excretion, we used to call it as microalbuminuria. That's no longer recommended. The term now recommended is moderately increased albuminuria. Likewise, Aniket is asking for MBBS. Davidson should be followed. Davidson is an awesome book. Yes, you can follow it. Shailesh says no, only Harrison. Um, Harrison is a gem of a book, but it takes a lot to understand Harrison in MBBS. Frankly, I'm saying there are people who are very, very good, who are able to read Harrison and understand and imbibe knowledge from Harrison even in MBBS. I'll be honest, I was not so good at understanding things from Harrison. When you start seeing patients, when you're doing residency, you're encountering patients, then Harrison starts making a lot of sense. But in your MBBS, how much ever you're exposed to patients, your understanding is limited. I mean, if you're not really seeing patient, if you're not involved in patient care, then it's not so easy to make sense of what's given in Harrison. It takes time for you to appreciate what really Harrison is. Harrison is it's an amazing, amazing book. Nobody has compiled information about so many topics in one place like Harrison has, but not easy to retain and make sense of what's given unless you're seeing patients and applying it. So you read something, you go and apply it, then it makes sense. So otherwise, Davidson is a very, very good book. There are so many good books these days. Achit Bulusar's book is followed quite 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 a lot here down south. Otherwise, George Matthew and Agarwal book is also very, very good. So a lot of good books these days. Davidson is a very, very good book. I would also recommend that. Yeah. So remember the terms. Severely increased is for more than 300 and more of milligrams of albumin per day, urinary excretion. And then the GFR values. EGFR 90 or more is G1. 60 to 89, this should be, sorry. 60 to 89 should be grade 2. And then 45 to 59 is grade 3A. The rest are like 15 ml. So 30 to 44 is grade 3B. Grade 4 is 15 to 29, and less than 15 is grade 5, which is basically ESRD. Or if they require renal replacement therapy. Anytime if they start requiring renal replacement therapy, like a maintenance hemodialysis, maintenance peritoneal dialysis and all that, then it becomes stage 5. Progress is asking, tell about AKI. Anything specifically you want to know? We just discussed about AKI for so long. If you have a specific doubt, then I'd be happy to answer it. Otherwise, I'll just try and finish off this CKD part. You guys don't need to know too much, I suppose, for CKD. Just remember what is the definition. I'm trying to arrive at the definition. The definition is actually EGFR of less than 60. Less than 60 ml per minute per 1.73 meter square for 3 months. Okay. Now, all of you will be able to tell me, all all of you will be able to tell me that though we are grading CKD as 90 and then 60 to 89, but you're defining CKD from 60 onwards. I mean, below 60 onwards. How can that be? What is the meaning of these two then? Okay, when CKD definition itself is less than 60 for more than 3 months, what is stage one? What is stage two? What is this grade one, grade two? That is grade one, grade two. Yes, so that is the complexity of the topic. Before 2012, the definition was below 90. Okay, and what happened was when the definition became below 90, 15% of general population became CKD. Okay, so 15% of population became CKD. So everybody was in nephrology circles, everybody was like, "What is this? How can we have such a large burden of CKD?" So that is why studies were conducted. When studies were conducted, it was found that when the GFR dropped below 60 is when all the complications of CKD increased. So complications of CKD tend to appear beyond, I mean, less than 60, including all-cause mortality, including highest progression of CKD. Uh, so that is why later in 2012, KDIGO changed the cutoff as 60. So now we consider 60, less than 60 for more than 3 months is CKD, but we still continue grading as grade 1 and grade 2. Okay. Um, which means 60 to 89 is grade 2, 90 and above is grade 1. So it allows you to identify people at risk. So let's say diabetic person, so diabetes is so prevalent. A diabetic person, you calculate the EGFR and it comes as more than 90, you can put him as grade 1 and still tell him that, okay, you're still not at risk for CKD yet, we'll follow you up. Whereas if they start going into grade 2, you can tell them, okay, you progress from grade 1 to grade 2, you have to be watchful. Let's keep monitoring you. Make sure you avoid NSAIDs. Make sure there's no other issues. Urine flow is normal, no BPH, no additional problems like that. So grade 1, grade 2 serve as they're asymptomatic. They don't have higher risk, very significantly higher risk of complications or all-cause mortality due to CKD, but it's mainly for monitoring. Stage 3A onwards, all the problems start. The progression becomes very fast. So the progression from this stage to this stage and beyond is much faster than from here to here or here to here. Okay. So from here, the progression becomes much faster. Okay, a lot of doubts. Progress is asking about anuria for 12 hours. Yes. See, even I don't know, I'll be frank. Anuria is defined as less than 100 ml for 24 hours. But stage 3 AKI says anuria for 12 hours. What we have to presume is less than 100 ml of urine for 12 hours. That is stage 3 AKI. But otherwise, explicitly, I have not come across anybody explaining what is this anuria for 12 hours. It's not mentioned anywhere. That is the thing. Aniket is saying you're in second prof. Tomorrow is your path pre-university exam, but I'm perplexed about the amount of topics we need to remember. Oh, that is, yes. I think harder than medicine exam was the pathology exam, especially systemic path, paper two. Uh, yeah, and I think we didn't even get an extra day to prepare for it. So I feel your pain, Aniket, but don't worry. See, finally, it's a university exam. Write something. Okay, make sure your page is filled. You will know something. You will that topic something you will know. Catch that point. Expand on it. Okay. So and you'll only feel like this. You'll feel like, oh, I've not read this corner of the textbook and I've not read these all the words that are there in the textbook. You don't need to. That feeling comes. That scary feeling comes that you've not read or you're out of 100 topics you've read only 30 topics. It won't. It's not the truth. You would have read something. Somewhere you would have got exposed about each of these topics. If a question is asked, you'll be able to answer it. It's not so easy to overcome that fear, but it'll seem a lot better when your exams finish. Tomorrow, when your exams are done, you'll realize, okay, I was more anxious than I needed to be. Anxiety is normal, but somehow get through it. Read whatever you can. Try and know a few points about all the topics which are there for the exam tomorrow. How much ever you can, you perform your best. That's all. Don't let the anxiety hamper your performance. Little bit of anxiety is inevitable. Farhan's asking less than 60 grading with proteinuria, diabetic nephropathy. Less than 60 grading with proteinuria or diabetic nephropathy. I didn't get you, Farhan. Reserve loss threshold proteinuria, threshold of proteinuria, glycosuria respected. Um, okay. Basically, if a patient has less than 60 EGFR, then the person is for more than for more than 3 months, then the person is considered to have CKD. Grading with proteinuria, these are the gradings. Either the patient has normal proteinuria, that means the albuminuria is less than 30 milligram per day, or it's 30 to 299 milligram per day, that makes him moderately increased. A severely increased albuminuria, that is 300 and more milligram per day albuminuria. With the proteinuria, diabetic nephropathy. Yeah, so that's the reason why this was included actually. Diabetic nephropathy is the most common cause of CKD, and they have a lot of proteinuria. That's why the albuminuria also started being included, and not just the GFR. Earlier it was only GFR, then it became both. You have to consider albuminuria and GFR both. Reserve loss threshold of proteinuria, glycosuria, respected reserve loss. I'm not getting your question, Farhan. Reserve loss threshold of proteinuria. Okay. You mean the blood level of proteinuria, glycosuria? No, I'm not getting what you're trying to ask. Maybe if you can frame it in a different way, I'll be able to understand. Okay. Uh, but at the same time, one thing you have to keep in mind is, see, even if the GFR is normal, if they're having high amount of proteinuria, so the color of the rectangles indicates the prognosis. Okay, how fast are they going to progress to ESRD? So at least in these two, it's green. So these are okay. Okay, and when it becomes yellow, the rate of progression is higher, and as it darkens for more and more, then the progression is highest, keeps increasing, and finally it's the highest risk. So it's marked here. Okay, and one more thing you should realize is, see this grade 3A only. If there's no albuminuria, it's yellow. If it is moderately increased albuminuria, it's orange, and it's pink if it is severely increased. So in the same EGFR also, the there is a change in rate of progression just based on the albuminuria. So that is why both need to be taken into account, EGFR as well as albuminuria. Okay. Yeah. So causes, most common is diabetic nephropathy. Worldwide, the most common cause of CKD is diabetic nephropathy. You guys know about diabetic nephropathy, a few words. So most initial changes, membrane thickening, okay, glomerular basement membrane thickening, and finally it leads to Himmelstein-Wilson nodules, PAS positive nodules in the mesangium, right? Not It's called nodular glomerular sclerosis. Nodular glomerular sclerosis. What are those nodules? They are Himmelstein-Wilson PAS positive nodules. Nodular glomerular sclerosis. Glomerulosclerosis. Okay. It is the most common cause of CKD. The kidney size is preserved. Kidney does not shrink. There's not too much of fibrosis, so there's not too much of shrinkage of size of the kidney. Okay, kidney size is preserved in diabetic nephropathy. A lot of albuminuria. Sometimes they have nephrotic range proteinuria. Okay, nephrotic range proteinuria. These few things you should, if you know, it's more than enough. There are stages of diabetic nephropathy also, but you guys need not know that. Just remember, it's the most common cause. Yeah. What are the other causes? What are the other causes of CKD? Hypertension related. So uncontrolled hypertension can also lead to CKD. Okay. When I said diabetic nephropathy, it's both type 1 and type 2. Type 1 and type 2, but a lot more common in type 2, because type 2 patients have insulin resistance. So as part of insulin resistance, they will also have hypertension. They'll also have dyslipidemia. So both these will contribute. So because of dyslipidemia, there will be renal artery stenosis. Because of high blood pressure, there'll be benign nephrosclerosis, and there'll be diabetic nephropathy. So combination of these makes type 2 diabetic patients much more prone to nephropathy than type 1, uh, at least much earlier than in type 1. Okay. Uh, yeah, so hypertension leads to CKD. It's called benign nephrosclerosis. Benign nephrosclerosis. Um, Kidneys will shrink. This requires the patient to have had a very high blood pressure for a very long time. Only then, maybe purely hypertensive patients can end up developing renal dysfunction, or CKD rather. Okay, what are the other causes? Ischemic nephropathy, renal artery stenosis, ischemic nephropathy, that is bilateral renal artery stenosis. Then what else? Autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease in adults we're talking about. Okay. Nephronophthosis. Nephronophthosis is the most common cause of CKD uh, in children. Okay, children, the most common cause of CKD is nephronophthosis. Farhan is asking, kidney size initially large in DM, then reduced due to hypertrophy. Yes, very good, Farhan. The initial problem with diabetes is there is an increase in GFR. There is hyperfiltration in diabetic nephropathy, very, very initial stages. So that maintains the kidney size. And even in later stages, no, even with the nodular glomerular sclerosis developing, there's not too much of shrinkage, not too much of fibrosis. So that is why, though there is scarring, it doesn't lead to an overall gross reduction in the kidney size. So CKD with preserved kidney size, diabetic nephropathy. Chavi says, good evening. Good evening, Chavi. Yeah. What are the other causes of analgesic? You should not forget. So any patient you come across, no, always ask for history of analgesic use or rather abuse. So ask them, do you have the habit of taking analgesic over the counter for headaches, for body pains, joint pains? Also ask them for obstructive uropathy. That means BPH in men, obstructive uropathy. Sometimes autoimmune disorders, especially like SLE, should also rule out, yeah, especially younger patients presenting with it. Sometimes, sometimes you don't get the cause. So it comes down to either chronic glomerulonephritis or chronic interstitial nephritis, basically idiopathic. You don't know what the cause is, but either something that predominantly affected the glomerulus or predominantly affect the interstitium. So chronic interstitial nephritis or chronic glomerulonephritis. But the most common cause is diabetes, diabetic nephropathy. Okay, what are the complications of CKD? So remember, stage 3 onwards, it will start, 3A onwards, these complications. So anemia to uremia, all complications are possible. Anemia is mainly hypoproliferative anemia because of reduced levels of erythropoietin. You guys told me erythropoietin is produced in the kidney in the peritubular interstitial cells. Peritubular interstitial cells. That's why in CKD, because of interstitial, it's called IFTA, interstitial fibrosis and tubular atrophy. So because of interstitial fibrosis and tubular atrophy, interstitial cells have erythropoietin producing cells. These will be lost and therefore anemia manifests. Then there are many other reasons why anemia occurs in CKD, including poor appetite because of uremia. So that leads to malnutrition. Sorry, malnutrition. Then there is congestive gastropathy. There's reduced absorption, entropathy and gastropathy, that is. And then there is hemolysis. Hemolysis occurs because of Burr cells. There is change in the deformation of the RBC membrane. That's called Burr cells. They'll appear like this. Some RBCs, because of uremia, they'll appear like that. Okay, blunted projections on the membrane, RBC membrane. Then there is blood loss, GI blood loss. That is again due to uremia. Uremia. Platelet dysfunction. That's platelet dysfunction. Okay. Then there's something called osteitis fibrosa cystica. Osteitis fibrosa cystica. This is due to high parathormone levels. Okay, slightly complicated, but basically bone marrow gets fibrosed. So the bone marrow becomes fibrotic and becomes cystic, filled with hemorrhagic fluid. That's also called as brown tumor of parathyroid. But it's not in the parathyroid, it's there in the bone. That's because of elevated parathyroid action. So basically, bone marrow is being lost. It's getting fibrosed. Uh, Abdul Aziz is asking, what is congestive gastropathy? Just what do you say? Not just the stomach, but the intestines also. Normally, it's supposed to have a branch of the uh, whether it's a tributary of the superior mesenteric vein or inferior mesenteric vein. Some mesenteric vein is supposed to allow nutrients to get absorbed, right? So whatever nutrients are there in the lumen, it needs to be absorbed into the vein. So if there is CKD, what will happen is there's too much of volume overload, because it's not getting filtered. The urine is reduced. Because urine is reduced, the intravascular volume is too much. So because of increased intravascular volume, there's increased hydrostatic pressure. So hydrostatic pressure, remember Starling forces. Hydrostatic pressure means from within the vessels, it's pushing outwards. So it's not freely allowing nutrients to get absorbed. So as a result of that, important nutrients may not be absorbed well. Not in the stomach. Just for saying it comes out as gastropathy, it's enteropathy. So congestive gastropathy or congestive enteropathy basically means there's congestion, which is causing increased hydrostatic pressure, which is not allowing nutrients to be easily absorbed into the veins. Okay. Yeah. So a number of causes. This is important because you can treat this. Sometimes there's something called angiodysplasias also. They can develop angiodysplasias. There's a number of reasons actually for anemia in uh, these are like vessel abnormalities, vascular abnormalities that develop in the intestines in CKD. Uh, there are more. I'll stop at this much in anemia. Why there is anemia in CKD? But the main cause is erythropoietin. That's why we'll treat like with this. We'll also encounter iron deficiency. They'll also have uremia. No, they'll have loss of appetite. So they'll have uremia. So they'll not eat much. So they'll develop iron deficiency. Plus they may have bleeding. So this can be treated. This can be treated with iron and vitamin B12 supplements if it's low. Uremia leading to platelet dysfunction can be treated with desmopressin. So desmopressin can be used for treatment of uremic bleeding because it improves the remember desmopressin is used for treatment of von Willebrand disease. That's the same principle where even in uremia it can be used, desmopressin. It enhances platelet function. Okay, so anemia is one of the early complications, one of the prominent complications. And of course, finally, nothing is working means you have to give blood transfusion. So every time they undergo hemodialysis, you can give them blood transfusion, PRBC transfusion. Thanks a lot, Farhan, for such kind words. Hypertension. Uh, Hypertension is also an early complication. Again, usually stage 3A or stage 3B, definitely they start developing hypertension. Why? Because low GFR. Now, low GFR will lead to increased RAS activation. RAS activation means angiotensin will lead to vasoconstriction, aldosterone will lead to volume retention. So all this will lead to hypertension. So hypertension occurring in CKD, not a surprise. Mm, Usually it will be resistant hypertension. This is one of the most resistant form of hypertension. Whatever you give, no, it will not work. Antihypertensives, how many ever classes you use, it will not work. So, and on top of that, you have to be careful. You have to watch the potassium level. So you can't really freely give ACE inhibitor ARBs also. Though they're good for preventing progression of CKD, you you need to keep an eye on the potassium when you're giving ACE inhibitor ARB. So instead, you will try and go with the other classes, beta blockers. Diuretics may not work because GFR is low. If you're giving thiazide diuretics, they may not work. GFR less than 30 means most thiazide diuretics stop working. So they're not effective antihypertensives. Then calcium channel blockers can be used. Alpha 1 antagonists, alpha 2 agonists like moxonidine. Sometimes we use other agents like hydralazine, uh, vasodilators, direct vasodilators. But the thing is, most often they'll have very, very resistant hypertension. So unless they start undergoing maintenance hemodialysis, the blood pressures remain very, very high. Okay. Um, and it's a vicious cycle. It will lead to further reduction in GFR. Hypertension leads to sclerosis. High pressure glomerular sclerosis will result. Okay, that's what benign nephrosclerosis, malignant nephrosclerosis. So basically, sclerosis of the glomerulus because of high perfusion pressures, leading to uh, replacement of normal glomerular endothelium with fibrotic tissue. Okay, hypertension, bone mineral disease or mineral bone disease, CKD-MBD, CKD-MBD, mineral bone disease or bone mineral disease. So this is a very, very complicated topic actually. So we discussed that vitamin D is low and GFR is low. So because vitamin D is low, leads to low calcium. Because GFR is low, it leads to high phosphorus. So low calcium means bad for the bones. So they are going to develop a form of osteomalacia. Correct? On top of that, because of these two, parathormone secretion is increased. So it's a case of secondary hyperparathyroidism. PTH, whenever the calcium levels are low or the phosphorus levels are high, both will stimulate PTH secretion. So PTH is getting secreted. What will PTH do? We discussed osteitis fibrosa cystica. It will cause bone marrow fibrosis. It will try and draw out as much calcium as possible from the bones. So what's troubling the bones? One is low vitamin D and high PTH. Okay, so all the calcium is being drawn out by the PTH to try and maintain blood calcium. Blood calcium is low because vitamin D is low. Because active vitamin D is produced in kidneys, here the kidneys are not working. So this is a problem. On top of this, there's going to be chronic metabolic acidosis. And one of the extracellular, one of the buffers, one of the alkali buffers for metabolic acidosis is calcium phosphate. Okay, calcium phosphate is present in the bones. So that is drawn out for trying to neutralize all the metabolic acidosis. Okay, remember, kidneys are supposed to throw out protons. They're not able to do it. So the proton needs to be neutralized by something. The calcium phosphate buffers get used up. So the bone is becoming weaker and weaker. So osteoclast activity is increased. Correct, Farhan. So with constant parathormone stimulation, osteoclast activity is increased. Calcium is being resolved, but it's not enough to increase the calcium levels actually. So total chaos. So in all this, what will happen if you give them vitamin D supplements or if you give them calcium containing phosphate binders, they will actually end up reducing parathormone. So a drastic reduction in parathormone in CKD is actually very bad for the bone. It leads to something called adynamic bone disease. So remember, you need a little bit of parathormone. Intermittent parathormone stimulation is necessary for good health of the bones. That's why when you're treating osteoporosis, you actually give a form of parathormone known as teriparatide. So treatment of osteoporosis, you use something called teriparatide, which is a parathormone analog. So adynamic bone disease results when you totally negate parathormone effects. Okay, so adynamic bone disease. The problem is whether it's osteomalacia, whether it's osteitis fibrosa cystica, whether it's adynamic bone disease, everything is bad for the bones. So risk of fracture is increased in CKD MBD. And when you do the X-ray, you will notice that there are alternating zones of normally ossified and rarefied bone. Normally ossified, then rarefied bone. So that is called rugger jersey spine. When you do a X-ray of the spine, I'm sorry. So rugger jersey spine is the name given to spine X-ray in CKD MBD. That's because of this kind of total chaotic bone health in CKD. Okay, so what do you do? What can you do? You need to bind the phosphate. So don't give them calcium containing phosphate. So when you're treating CKD, MBD, what do you do? Very important. Low vitamin D. How do you treat low vitamin D in CKD? What do you do for the high phosphorus in CKD? So remember, you can't give cholecalciferol. Usual cholecalciferol you can't give because cholecalciferol is 25 hydroxycalciferol. What is commercially available, what we recommend for most other patients is 25 hydroxy vitamin D. 25 hydroxy vitamin D is no use in CKD because it needs to be activated with 1 alpha hydroxylase, which is missing in CKD. So you can't give cholecalciferol or 25 hydroxy vitamin D. You need to give calcitriol, which is active vitamin D. So treatment of bone mineral disease, hypovitaminosis D in CKD is with calcitriol, that is 125 dihydroxy vitamin D. Okay, please remember that point. High phosphorus, what do you do? Don't give calcium acetate. If you give just calcium acetate, this calcium level will normalize. Once calcium level normalizes, the PTH secretion will reduce. That will lead to adynamic bone disease. So instead of calcium acetate phosphate binder, give alternative phosphate binders like Sevalemma. This is what we generally use. Sevalemma 400 mg PAD. Sevalemma or um, you can use other compounds also. Strontium acetate you can use, okay, or Sevalemma or strontium acetate, but not calcium acetate. Okay. Avoid calcium containing phosphate binders. Also, there's something called paracalcitol. Paracalcitol, which does not reduce it. It is a form of vitamin D, activated vitamin D, which can be used in CKD. It doesn't. It improves vitamin D levels, but does not reduce parathormone levels. So better for the bones than giving plain calcitriol. Calcitriol, what will it do? It will reduce the parathormone levels. Sorry, it will reduce the parathormone levels because calcium levels will increase when you give calcitriol. So paracalcitol is one form of vitamin D which does not do this. Doesn't it improves calcium levels without reducing parathormone? Doesn't have that feedback for reducing parathormone. Okay. Okay. Right. So that's adynamic bone disease. What are the other effects of CKDs? Uremic frost. Uremic frost can occur. Urochrome. Urochrome means dark pigmentation. So if you've noticed CKD patients, all of them will have a dark skin complexion. That's because of urochrome deposition. Okay. Uremic frost. Sometimes the urea will only come out into the skin. It will appear salty. Very, very high creatinine value patients. So uremic frost may occur. Uh, they can have other manifestations like perforating dermatosis. Um, you guys don't need to know all that, I suppose. Chronic lichen simplex. They'll have so much itching. No, pruritus is very common in patients of CKD. So because of repeated scratching, they'll develop lichen simplex chronicus. Okay, perforating dermatosis. These are all skin manifestations of CKD. And drug elimination is impaired, so that's why you have to be careful. So CKD, for example, see, diabetic nephropathy is the most common cause of CKD. So in these diabetic nephropathy patients, if they're receiving metformin, you have to be careful. Metformin can lead to lactic acidosis. So if the patient has CKD stage 3A, you can continue metformin, no problem. If they reach stage 3B, if they're already taking metformin, continue at half dose. If they're not yet on metformin, don't initiate metformin. Okay? Clear? Stage 3A, no problem. Stage 3B, if they're already on metformin, make the dose half. Or if you take it out, if you want to be safe, patient agrees to go on to insulin, stop the metformin, you take it out to be safer. Or if they're not yet on metformin, don't initiate it. If they're stage 4 or 5 CKD, then stop. Don't no metformin at all. Because risk of lactic acidosis is high. So like that, you'll have to be conscious about what drugs the patient is taking. There may be nephrotoxic drugs or drugs which require dose adjustments. So you have to be careful. Okay, uremic complications. What is up with the what is what are the uremic complications of CKD? So nausea, vomiting, low appetite. That is the more basic one, low appetite. Then there can be uremic bleeding. There can be pericarditis. There can be encephalopathy. Correct. So the thing with these is nothing else will fix it except maybe uremic bleeding where you can give desimopressin. Most other uremic complications, nothing else will fix it unless you do renal replacement therapy. So once they develop uremic complications like these, then no other choice but to go for renal replacement therapy. Anemia means you can have some treatments like erythropoietin and erythropoietin stimulating agents, or the newer drugs like HIF inhibitors. Um, or if they have hypertension, you can try with antihypertensives. Bone mineral disease means some therapies are there. But then if they develop uremia, there's almost no other way apart from going for hemodialysis. You have to go for initiation of hemodialysis in a CKD patient. Okay, clear? Yeah. This is for the nephrologist to do. They'll either go for hemodialysis, peritoneal dialysis, renal transplantation. This is like beyond us. But what can we as physicians do? Uh, Hypertension we discussed. Anemia, yeah. So anemia, what can you do? If they have iron and B12 deficiencies, please correct them. Almost certainly they'll have, because they'll have loss of appetite, they'll have uremic bleeding, so and gastropathy and enteropathy, congestion basically. So they will have high risk for malnutrition. Correct that. What else can you give? Erythropoietin stimulating agents. So either you can give recombinant erythropoietin, or you can give dabopoietin alpha. Dabopoietin alpha. Sorry, dabopoietin alpha. Dabopoietin alpha. Okay, these are erythropoietin stimulating agents. They will uh, mimic the action of erythropoietin and stimulate its receptor to on the bone marrow to try and increase erythropoiesis. And then there are newer drugs which are hypoxia inducible factor prolysyl hydroxylase inhibitors. Okay, what are they? Earlier we had a drug called daprodustat. Now we have, in this year 2024, there was a new drug approved that is called vadadustat. So not yet being used clinically as much, but you need to know the theory part. So daprodustat and vadadustat, these are drugs which are HIF prolysyl hydroxylase, so HIF PHI inhibitors. Okay, daprodustat and vadadustat. And then if it's very low, then PRBC transfusion. Okay. Yeah. And then what else? We discussed about calcium phosphate binders. Uh, if there's hyperkalemia, then low potassium diet, maintenance. You can give them something known as patiromer, which is a phosphate binder, apart from polystyrene sulfate. So sodium polystyrene sulfate or calcium polystyrene sulfate you can use for potassium binding. And volume, so refractory volume, if they're having a lot of volume, that means if they're having pedal edema, refractory to usual diuretics, GFR is low, your diuretics, how do they work? How do your loop diuretics or thiazide diuretics work? They have to enter from the luminal side. So they have to enter into the lumen first. They have to get filtered first. If the GFR is low, they're not even going to get filtered. So they're not able to act. So that's why their efficiency comes down. Except for one type of thiazide diuretic that's known as metolazone. Metolazone you can use even when the GFR is less than 30. There is one thiazide diuretic or thiazide type diuretic. Actually, it's a thiazide type diuretic which you can still use when the eGFR is less than 30. That is for volume. Um, what else? Beyond this, you have to prepare them for RRT. So for hemodialysis, you have to vaccinate against hepatitis B and plan for an AV fistula creation, and then prepare for hemodialysis like that. Or you have to put them on the transplant list, so renal transplant. So work them up for renal transplant, potential donors, like that for CKD. Okay, I think, yeah. Just one last slide. What is the difference between acute kidney injury and CKD? So toleration of uremia. So if you see a creatinine of like 16, 17, 20, no way it can be acute kidney injury. No way. In an acute kidney injury, this much of creatinine, it will never reach. Before that, only the patient would succumb. Okay, so if you are seeing values like this and the patient is like walking around, that means CKD. Cannot be acute kidney injury. It's the reverse with the hepatitis. Okay, fulminant hepatitis, the enzymes will be in thousands, but in chronic hepatitis, it will not. It will never be beyond 1,000. So when enzymes are very high, it's likely to be acute or fulminant hepatitis. Whereas if creatinine is very high, then it's more likely to be chronic kidney disease. Okay, kidney size generally preserved in obviously in acute kidney injury, shrunken in chronic, except the most common cause, which is diabetic nephropathy. Then there are other exceptions also, like amyloidosis, like autosomal dominant polycystic kidney disease, like HIV-associated nephropathy. These are all slightly higher points. I'm sorry, they come out. But remember, diabetic nephropathy, kidney size is preserved. Cortical echogenicity is normal, increased. Um, Normally, the cortex, no, when this is the kidney, if you do an ultrasound, the medulla will be quite echogenic, but the cortex is not so echogenic. But if there is increased echogenicity and there's loss of corticomedullary differentiation, these points favor CKD. Anemia, obviously more common in CKD. CKD MBD is more common in CKD. Okay. Yeah. With that, we'll conclude the long discussion on renal dysfunction. Any doubts, guys? Oh, sorry if I failed to clear any of the doubts you had asked in between. So remember renal causes, remember about both AKI and CKD. Remember the causes. Uh, Staging. Staging is much more important for CKD. Um, for AKI, it's more theoretical, I feel, anyway. But you should remember. Definitions, you remember. Definitions and staging. Definitions. And then something about complications and treatment. No doubts? Okay, sorry, the class stretched on for much longer than I thought it would, but the topic is like that. Okay, if there are no doubts, I'll close the session here. Thank you so much for joining and making it a very interactive